April is Oral Head and Neck Cancer Awareness Month, a time dedicated to education, early detection, and prevention of these serious health conditions. We are truly honored by the presence of distinguished guests, respected faculty members, healthcare professionals, and students from across Pakistan. I am Dr. Saman Sultan, serving as the Assistant Director at Pride. With background in dental surgery and academic teaching, I'm committed to supporting initiatives that elevate the standards of dental education and public health awareness.
Assalamu alaikum everyone. I am Dr. Tuba Usman, serving as the Associate Director at Pride. I hold a Bachelor's of Dental Surgery degree and I am currently pursuing on to my Master's in Public Health. I also hold certifications in endodontics and implantology, and I am a certified health quality professional from PIQC-DUHS. Today's symposium is dedicated to a vital cause. April is globally recognized as Oral Head and Neck Cancer Awareness Month. These conditions, though widespread, often remain undiagnosed until advanced stages. These cancers are among the most common globally, yet they often go unnoticed in their early stages due to mild or overlooked symptoms. Risk factors such as tobacco use, alcohol consumptions, HPV infection, and poor oral hygiene significantly contribute to their development. However, if diagnosed early, the chances of successful treatment and survival increase dramatically. In this context, today's symposium aims to shine a light on this serious health concern through expert talks, research presentations, and clinical insights. We hope to equip attendees with knowledge that can lead to better awareness, timely diagnosis, and ultimately life-saving. Through this event, we aim to raise awareness, encourage early detection, and emphasize the role of education and community involvement in prevention and timely management.
Allow me to begin by introducing the institution that has brought us all together, PRIDE, the Pakistan Research Institute of Dental Education. PRIDE is an academic and research platform committed to uniting the dental education community, expanding opportunities for students, and fostering a culture of collaborative research. Our mission is to educate, empower, and engage future researchers by providing accessible research slots, expert-led mentorship, and free publication opportunities through partnerships with reputable journals. PRIDE has successfully conducted several insightful webinars in the past, graciously presided over by dedicated hosts, and honored by the presence of respected and esteemed guest speakers. PRIDE is proudly led by a team of passionate directors and campus ambassadors who voluntarily contribute their time and expertise to promote academic excellence and research advancement across the country.
At the heart of this initiative is Dr. Farooq, the founder and director of PRIDE. He graduated from Magala Institute of Health Sciences in 2021 with a degree of Bachelor's of Dental Surgery, earning a distinction in oral medicine. Driven by passion for teaching and academic mentorship, Dr. Farooq also runs a successful YouTube channel, Experience Dentistry, which has over 5,000 subscribers and has mentored and guided numerous dental students across Pakistan. Currently, over 25 research proposals are being supervised by Dr. Farooq through the PRIDE platform. He has 2 research papers published in national journals and 1 international publication. Congratulations to Dr. Farooq, co-authored with Dr. Anas, titled Non-Invasive Treatment of Early Childhood Caries. His leadership, vision, and dedication to dental education continue to inspire the community.
The success of the symposium is the result of the unwavering dedication, vision, and collaborative efforts of our esteemed organizing team, comprising experienced educationists, enthusiastic researchers, and committed professionals. The team worked tirelessly behind the scenes to curate a meaningful and impactful event. From conceptualization to execution, Each member played a vital role in ensuring the smooth conduct of the symposium, reflecting their shared passion for advancing dental education and research. We extend our heartfelt appreciation to the entire team for their hard work, creativity, and commitment to excellence. We are especially honored to be joined by esteemed and highly accomplished guest speakers from across Pakistan who have graciously taken the time to be with us today. On behalf of Pride, I extend my heartfelt gratitude to each of you. Your presence and contributions are deeply valued and appreciated.
It is my great pleasure to welcome Dr. Carolina Benitez, an internationally acclaimed dentist from Uruguay with expertise in laser dentistry, endodontics, and implantology. Dr. Benitez is a sought-after speaker, having presented at numerous international conferences and events. Her contributions to the field of dentistry are valued globally, and we are honored to have her share her insights and expertise with us today.
As part of our ongoing research on oral cancer, I would like to request you all to kindly take a moment to fill out the feedback form from being shared in the chat box. Your responses will greatly support our data collection and contribute to meaningful findings in this important area of study. Audience, you are given 5 minutes time to fill the feedback form given in the chat box. Meanwhile, I share the schedule for our 2-day symposium.
I hope you all must have done with the feedback forms. Uh, let's just warmly welcome our speaker, Dr. Smile Wayman. It is truly an honor for me to host Dr. Smile Wayman, a highly accomplished and dedicated professional in the field of oral and maxillofacial surgery. Given the depth of his achievements, I'll keep the introduction concise yet comprehensive. Dr. Mayman is a distinguished graduate of the Akat University of Medical and Health Sciences, Jamshoro, and holds an FCPS in oral and maxillofacial surgery. He successfully completed his FCPS Part 2 trainings at Dr. Ziauddin Hospital, Clifton, one of the leading institutions for surgical training in Karachi. He has served as a senior registrar at PEPS Hospital and is currently working in the same capacity at Indus Medical College. Alongside his academic role, he also practices as a consultant oral and maxillofacial surgeon at the same institution, where he continues to provide expert care and surgical excellence. Amazing. We're privileged to have him with us today. Please join me in welcoming Dr. Smile Neyman. Dr. Smile Neyman, over to you.
अस्सलाम वालेकुम। क्या मेरी आवाज़ सबको आ रही है? हेलो, अस्सलाम वालेकुम।
यस सर, आपकी आवाज क्लियर है, इट्स परफेक्टली फाइन।
Okay, do I start or I should wait for 10:30?
यस सर, यस सर, यू शुड स्टार्ट।
Bismillahirrahmanirrahim. We are celebrating the Oral Cancer Awareness Week to create and aware people regarding the oral cancer. So I am thankful to all of you for joining us, and also I am thankful to Pride Research Platform that provided opportunity to discuss about the oral cancer. Before starting about oral cancer, I should Yes, I am Dr. Mohammed Ismail Mehman. I am consultant oral maxillofacial surgeon. Right now working at the Department of Oral and Maxillofacial Surgery at the University of Modern Sciences, Tanno Muhammad Khan. And I'm doing surgeries at Tanno Muhammad Khan in Hyderabad and Karachi as well. So before starting my lecture, all participants should know what is oral maxillofacial surgery. So it is a surgery of face, jaw, and mouth. Deals with the diagnosis and treatment of different conditions of oral cavity and face, jaw, mouth. It includes soft tissue pathology like oral cancer, and it also includes the soft tissue infection, cellulitis, and trauma, and it includes jaw joint deformities and joint disorders, facial deformities, and issues with the salivary gland, and minor oral surgery includes wisdom tooth extraction and dental implants. Before I start talking about oral cancer, we all should know what is cancer. So basically, cancer is uncontrolled growth that invades to the different parts of body. And we all know there are two types of cancer. One benign, that grows slowly and do not spread to the different parts of the body. And another tumors are malignant tumors. They invade surrounding structures and grow fastly. So oral cancer we are talking about is malignant tumor and it is called oral squamous cell carcinoma. So basically, it is malignant tumor of the epithelium, right? Any carcinoma, any malignancy of the epithelium is known as carcinoma. So hence it is called oral squamous cell carcinoma. Uh, yes, I discussed about the cancer cells. Uh, Before further starting, we all should know why we are talking about the cancer. Everyone knows about the breast cancer awareness program, but majority of us are not aware about the oral cancer. It is the leading cause of death in men. Cancer causing death number one in men is oral cancer, and number two in women. Uh, Breast cancer is number one, but oral cancer causing death in women is number two. So this is a study was done in Pakistan, and it shows a huge impact of this disease, of the burden. Right now, it is more prevalent in the provinces, especially Karachi, Hyderabad, and we know what causes oral cancer. So 95% of the patients that are suffering from oral cancer, it is due to the tobacco usage, like pan, hookah, thalia, betel nut, and it is also common due to the alcohol usage and the smoking. Uh, I know most of the students are there, so they had gone through the literature. Literature shows and says it is due to the human papilloma virus, but it is only literature for the European countries. No state for the Pakistan, India, and Bangladesh, where the most common cause is tobacco, and the same pattern is causing the cancer. In European countries, alcohol usage with smoking cause oral cancer. But in our country, tobacco products are the only major cause because 95% of the poor, privileged, unprivileged population using these type of substances and hence more prone to this disease. And other than tobacco usage, different conditions also causes oral cancer that includes chronic infections and previous history of the cancer and immunodeficiency. So before starting further talking about oral cancer, we all should know how cancer starts. So basically, there are three factors. One is genetic factor. We all know there are mutations in the genome that causes uncontrolled cell growth. But environmental factor is the major factor because these type of substances we use, they cause mutations and they cause the deletions and they cause methylation of the DNA and they suppress the growth of tumor suppressor genes like P53, P16 and other genes. They promote the growth of tumor growth factor, tumor promoter cells. So hence the mutations and these whole proteins cause the uncontrolled growth and there is a start formation of the malignancies. So majority of the patients present to us are going through different conditions. According to different literature, there 60 to 70% of the population suffer directly lesion, that is cancer, but 30% to 35% of the population are going through these type of conditions. That is, there is a white patches on the cheek and different spots on the cheek and jaw and basically, it is not necessary that every patient gets cancer directly. There are certain, what we say, markers and conditions that shows there are more chances. Most common condition is oral communicable fibrosis. This is common chronic disease. This is disease of patients who are using Erica nuts and Erica nuts and betel nuts. So what this causes? This causes the fibrosis of the epithelium and hence there is hardening and patient cannot open the mouth. And also different things like naswa, it causes the white spaces over the alveolus and there is also a red lesion that is called astrophylacia. So these are the different lesions and conditions that start before start developing cancer. So we know there are seven subtypes of oral cavity. Lip cancer is most common in the smokers, and it is also common the person who are exposed to the sunlight, like our laborers, they are used to work in sunlight, so they are more prone to this disease. And also, the lip cancer has a good prognosis. Why? Because the lip is the only side that is visible. When person comes to you and talks to you, you notice certain changes. So hence it is the cancer that is early diagnosed and having the good prognosis. In the European countries, most common site of cancer is tongue, but this is not in Pakistan. European countries, I already told, in European countries, alcohol and smoking causes the cancer. And once a patient is taking alcohol, so basically it uh, it is causing more erosions of the floor of the mouth and it stays there. So hence it causes cancer in the tongue and the floor of the mouth. Both in Pakistani population and Indian population, the cancer patients are using little nuts. So hence they chew and keep in the buccal mucosa. So most common site of cancer in Pakistan and especially in our center where I worked for 2 years consequently and I did 200 surgeries. It is cheek, buccal mucosa, simple. Uh, and even most of the patients are present to us were having tumors on the left side. Up to I did my figures, it was up to 60% of the patients had cancers of the buccal mucosa of the left side. So hence, the buccal mucosa is the common site in our population. And the next most common site is alveolus. Alveolus of the mandible. It is also the common site of the cancer. And this is the picture showing the tumor of the mandible. And we cover the three sides. Fourth site is the palate. Palate cancer is mainly seen in the reverse smokers or in the person who are using the different electric vapes in very high amount. It is not in the routine patient. The next site is the retromolar trigone. It is area, it is posterior to the third molar uh, between the and anterior to the postal pillar. In this picture, you can appreciate. And the next common site is the tongue and the flora of the mouth. These seven subtypes of the oral cavity. And why we are discussing with you guys, because the patient mostly presents to the dentist and to the different family members, and they used to take suggestion from a layman. So I want to share my opinion that if any person, any patient presents with you, we should be able to catch it early, and we should send this patient to the maxillofacial surgeon for earlier diagnosis and earlier treatment. Every ulcer is not cancer. So our patients, they come to us and later stages because they are basically ignorant of the disease. They do not know about the disease and they are not properly taught and advised uh, correct options by the people around. Time is the key. I am is thinking about you people that are joining us, and they should be able to diagnose and they should be able to teach these patients that they should come to us earlier. Earlier, if patient present to us earlier, then we can catch the disease in earlier stages, and there is a very good prognosis. So every tumor or cancer starts with a small ulcer. It's just like a bubble, a small 1 centimeter diameter hardly. Grows inside, and patient again resting in time. So they present to us mostly in the third or the fourth stage. So he is earlier diagnosis. So simply, we think everyone should know about the time period. Any lesion that is occurring in the oral cavity is not healing in 2 weeks. It should be consulted by the oral maxillofacial surgeon. Simple ulcers that are more common, and we all have gone through these type of ulcers. They subside in 7 days, even without treatment. So there's nothing to worry about any ulcer that heals in just 5 days. For any ulcer that doesn't heal in 2 weeks, it should be seen and it should be checked by a proper oral and maxillofacial surgeon. I'm not saying it's cancer, but if it is cancer and it is in the earlier stages, the surgery is as simple as excisional biopsy. So it will take only 5 to 10 minutes, nothing more, and it will not cost any. It will not burden patients. So earlier diagnosis saves life, saves money, saves resources. So there, so if patient is not taking treatment, then they waste the time. The tumor progresses through the different stages to the last stage. So we have the data of the subcontinent and Asian countries. So 5 year survival rate if the surgery is done, is still no tumor is around 85%. So this is a huge percent. So it shows the importance of earlier diagnosis and earlier treatment. Stage 2, 70 to 80%. Stage 3, 55%. And stage 4, 5 year survival rate is around 10%. So see, there's a huge difference after every stage. So basically, we all need to be aware of this disease. We all should be able to teach the patient they should come to us earlier to save lives. So when patients present to us, I'm talking about my experience around 200 patients. Uh, they have different myths in their mind, and hence they do not start proper treatment. They believe in different things. So there are four most common myths that patients believe. One is one is Hakimi Toke. This is the herbal medicine and different dam durud. I'm Muslim. I'm not saying this is wrong, but if you are using these type of substance and in 2 weeks you do not found any huge difference and still disease is progressing, why you are wasting the time? So most of the patients that come to us, they are wasting their time by going through these type of the persons hacking. Why? Because they are anxious about the disease and they are anxious about the treatment. So second most common myth is extraction causes tumor. So this is again myth. Most of the patients they are anxious about the dental procedures and that they worry about the extractions and they have believed that if any person is having extraction, there is a chance of tumor. So basically, our patients that are facing all stomach cell carcinoma are mostly little nut users. So there is no link of extraction to the uh, tumor development. Basically, sometimes there are tumors of the mandible and there is a loosening of the tooth. And if dentist is not that much expert, they are not getting the signs and ulcers, and this causes the erosion of the mandible and that causes the bone loss and mobility of the tooth. They are expecting the teeth, and the hence patient is thinking that tooth extraction caused the tumor. The third most common myth that patients believe is cancer is contagious. Uh, Most of the patients that came to us, their family members are more afraid. They are not coming closer to this patient because they think if they touch the tumor, it will transfer to them. So you people should be able to understand and teach them that this is only myth. Tumor is not contagious. It doesn't. It is not transferred by touching and anything else. And most common and most important factor that patients are refusing the treatment is biopsy. They have believed if a patient gets the biopsy and they will die they will die of the disease. So this fear hinders the treatment. This fear transfers our patient to these type of hakims and they start believing totally because they want to avoid the biopsy. Basically, they think if they will get the biopsy, then the tumor will further spread. So before talking about biopsy, the dentist or the surgeon or any person who is looking after the patient should know why we are doing the biopsy. Biopsy is just beginning of the treatment. It is not solely treatment. Biopsy is just procedure to proceed with the surgery. And if surgery is not possible to proceed for the chemo and radiation. So our patients they get the biopsy done and then again they do not come to us for treatment and hence they are lost to follow up and they again dying of the disease. Regardless if patient is getting treatment or patient is not getting treatment, cancer will spread. So we should talk about the biopsy. It will not spread and we should not wait longer. If patient is willing for biopsy, we should teach them that after biopsy, they have to be they have to get CT scan done and the surgery should be done. If they are not willing for the surgery, they are not willing for the chemo radiation, there is a no value of doing biopsies. Just it is just piece of paper and it's again promoting the myth and necessarily if patient is not getting the treatment, the patient will die. Surely he or she will die of the disease. So again, before dying, they will promote, I got this biopsy done. So for biopsy, everyone should be very clear about the indication. Patient should be very clear why we are doing the biopsy and what will biopsy done and what is the next step of the after biopsy. So the whole program that we are talking about is to prevent and to aware the things. So first of all, if anyone is using different things like betel nut, they should stop eating it. Acha, patient also believes that if he or she stops the type of habits, there is a no chance of cancer. They think that there is no chance now they are disease free. So we should be able to teach the patient if patient is not using betel nut and erica nut and this type of material, the risk for development of the cancer is strong. But it is not progressing, but it will be there. It means if patient is alive for next 50 years, there are chances because the damage that has already been done can cause the cancer. But if they are not stopping, they are not quitting the habit, the risk will again multiply. So we should be able to teach them to stop habits for what? To stop the risk. It means the that damage that has already been done, it shouldn't increase it, right? So stopping habit is a mandatory step, and any person who had used this type of material should visit oral and maxillofacial surgeon at least 6 months or 1 yearly, annually. He or she should visit for routine checkup. And main thing is any ulcer, any lesion that develops on the oral cavity and is not healing in 2 weeks, it should be consulted earlier. And mainly, all of us are going through the society who are exposed to the betel nut. If we are not using, our family is not using, but our workers, our surroundings, our relatives are using these things. If we people are not aware of this, then how can we create an awareness? So there should be a community program. There should be early referral programs. And there should be more awareness sessions like online virtual symposiums is really good awareness step to create awareness. So before talking about treatment, we should be able we should be able to talk about the myths and mysteries to the patient, not for us, but for our families, but for our relatives, or for our surroundings. Basically, there are three treatments that are currently we are using for any patient that is going through oral cancer. The mainly treatment is one local excision. That is the only treatment that can finish, that can completely get rid of the disease, that completely 100% can remove the disease is surgery. So surgery with a good margin is the goal. If patient is in stage one and in the stage two, then surgery is a just by excision. There is a less what we call morbidity, and if tumor is larger, then it requires more wide local excision and it causes more facial deformities. So surgery is not tumor excision, but we also require neck dissection. So neck dissection, there is also debate in first stage tumor whether we should go for the neck dissection or not. But it is again the part of the treatment. Patient believe most of the patients that are inoperable or that are going through the German sections, they believe that the only solely treatment is chemo and radiation. So I have gone through the many patients. They came to us, they had radiation and they died of the disease, and their parents and their relatives they start promoting propaganda that treatment is nothing but a bullshit. It is failure. It is again causing the death. If someone is referring patients to the chemo and radiation, then we should be able to teach them this is not treatment. If the disease is stage 3 or stage 4 and patient is only given the chemotherapy, radiotherapy, so it will only stop disease progression or it will reduce slightly. Chemo radiation cannot eliminate third or fourth stage tumor. Surgery is the only option. So again, our government sectors are not that much proactive to provide that much surgical care. So hence they just do the biopsies and send the patient for the chemo radiation. I'm not criticizing our government department, but I'm just talking about the reality because we people will be exposed to the next generations of the patients that has been offered only chemo radiation, and and again their generation will believe that chemo radiation is the only treatment and it is not better and it is not working. Their patients are dying of disease after having chemo radiation. So myths start from these types of things. If patient is not operable, then his attendant and family should be clearly and even patient clearly informed that the chemo radiation will only stop disease growth and it will only reduce disease slightly. Uh, there is no 100% cessation of the disease. These are the basic things that our patients are not aware of. Even the most of the patients they have never been told that why they are going to seek for radiation, and that they even do not talk about these things. They just create fear and mess in their surroundings. So basically, the main role of the society and take home message of our patients is we should be able to inform the disease, inform the problem to the patient, and our surroundings should be informed about the disease. They should be aware and they should be provided basic knowledge for the oral cancer because it is prevalent is breast cancer. And we should also inform and promote the different literature and the sessions to stop these things. Even our police department is totally failed to stop these type of substance retailers and farm goods. So it's government duty, not our duty to stop these type of material usage in the population. But still, we can only make the thing good by working on us. So the medical community, they are the backbone for the education. They should teach the patient about the problem. They should teach them avoid using these type of substances. They should teach them where to go, when to go, whom to consult for oral cancer or oral cancer problem, and they should be consulted for the earlier diagnosis and earlier treatment. That is the 2 week formula. Any ulcer that is not healing in 2 weeks, it should be consulted and should be treated. If it is not cancer, then it only requires different medication. If it is the cancer, then it requires only 5 to 10%. That is it. And we should also promote the literature, stop believing in myths and mysteries and and we should also support and help patient to make a decision, and we educate the patient for the decision of the treatment, and that we should also support patient families uh, are going through these types of procedures. Surgery is not a one-day game. It requires a week for healing, and it requires at least 10 days for surgery, and up to 6 weeks we will require for complete healing. And sometimes most of our patients they are able to go back to their routine in 2 weeks. But family should be informed it can take 6 weeks for the surgeries, and after surgery, if there is a need of chemoradiation, then they should be informed that chemoradiation is again not a one-day game. It requires a time. And one thing I forgot to mention that chemoradiation works only after surgery. If we did the surgery and again disease will progress and disease has reached the neck nodes and there metastasize to the neck, then chemoradiation should be given. And even radiation is recommended for the patients for the advanced stage disease. So chemoradiation only works as a supportive agent rather than solely agent. The main take-home message for my presentation is to send patient earlier and to save life earlier. And doing surgery is not an easy thing. It needs a lot of money and support. So in government sectors, they are not providing that much care. So the burden is mainly on the patient himself, herself. And this is our role, and this is our this is the our we should help them, and this is the only way to go through this. If a patient is suffering from oral cancer and you are living nearby them or you are closer to them, you should support them financially, mentally, and you should encourage them to go through the treatment. And basically, what we are offering, we offer free screening every Wednesday and free checkup Wednesday. Every Wednesday in the Medical College in Ramadan. And we are also offering free of course checkup and screening and even biopsies at the Hospital Medical Care Hyderabad. We are working as a team, I and Plan, we are working on oral cancer. So we are creating societies for raising the awareness. Surprisingly, we had a camp on 11th of April of this month. So shockingly, there were 76 patients. Out of 76, 74 were suffering from cancer. We arranged camps for only cancer patient in the simpler area of the Hyderabad. It's called Pakka. So 74 patients of malignancy were living there without getting treatment. So we know the burden of the disease. So now we have to work for this. Thank you guys for listening and any questions and any remarks on more than happy to answer and please.
Thank you so much, sir, for insightful and impactful session. The way you explained the importance of early detection and awareness of oral cancer was truly eye-opening. I think it's time we should address some questions we have in the chat box. Okay, first question is from Dr. Imam. Why over primary healthcare? Okay, why our primary healthcare are not educating to our local population? Why are seniors of oral maxillofacial surgery not discussing with government to create barrier to stop etiological factors, mostly gupka using live feed?
Very good question. I know my friends that are working against the government, even with the government, but they are just giving us a false hope that they are working. Even there are different persons we approach, like our health minister, Dr. Azrafi, so we went there. But again, we were just they just gave us false to the wrong authorities and their wrong stories. So question is why government is not doing I can only simply say there is a huge money market, corruption market behind these type of materials that take different material. I will talk about my hometown, Mohammed in Hyderabad. I know that the government level administrative officers are involved in their purchase and sale. Why healthcare, primary healthcare are not educating? This is the main question because our physicians, patient, where will patient go? Most of the patients go to the primary centers where they are going routinely for checkup, for fever, diarrhea, different type of diseases. So mainly patients go there. So most of the even doctors do not knows about this problem and they are even not guiding correctly. So hence we started this awareness campaign to create awareness for even doctors. And in 24th of this month, again, I had put a great seminar in the University of Modern Sciences again regarding the awareness. But primary healthcare should be able to teach the patient about the disease and they should be able to refer patients appropriately. So we have failed referral system. There should be proper referral system. So this will help and this will save the lives. Simply, I cannot address why primary healthcare are not that much proactive. But I think the awareness creating programs will help, and we should. This is not one. We can overcome this problem.
Dr. Laiba has a question. What other diagnostic tests should be done other than biopsy?
Practically speaking, I have treated many patients without doing biopsy, so anyone can criticize about this. But it is my approach because most of the patients they are so much hard to counsel about the correct way. Even I did surgery 2 days ago. There was tumor of the tongue that was so long. It was they were he was suffering from this disease since last year. So even they didn't go through the treatment. So they were afraid of the biopsy, but they were ready if I'm doing direct surgery. So we know because I'm treating the disease since 8 years. So I know what is cancer and what is not cancer, but why we require biopsy is just a evidence and just a legal paper for starting surgery. But most of the time we have no other disease in the differential diagnosis where patient comes to you with the erosive on the tongue and he's using vital nerves and is not healing since here. So what is your different diagnosis? You have no any other disease with that severity other than all cancer. And there are scientific studies are going through saliva, salivary protein biomarkers, but they are not that much definitive and they are not that much uh, appropriate to work solely on this material. But we can do it. We can get the CT scan done. So CT scan tells us about the seriousness and the destruction that is done by the cancer. But up to now, we have the only biopsy that will tell us 100% that it is cancer or not. If it is the cancer, then it is well differentiated or moderately differentiated or poorly differentiated. These variants will tell us about the type of cancer patient having. For the poorly differentiated is fast growing tumors, so it should be addressed earlier. But up to now, biopsy is the only way till we can diagnose it 100%.
Dr. Paras says, sir, please further elaborate Hakimi Totka.
Yeah, even there's one famous Hakim in Dhaka. Mostly advanced stage disease patient when they come to me, I always ask them where were you before. They are again starting making stories, but I know that I just again repeat the question: where were you before? Then if then if you will emphasize and you will start a harsh little bit, you will go more overconfident. Then they will tell you that where were they before. So even in the Theta, there is a famous Hakim. Even the 50% of the lately diagnosed patients go there. Even you will not believe my car driver. He had cancer 4 months ago, and I told him it was his fixed one. I tell you cancer, you should get the surgery done, and I will finance you. But just get the CT scan done at your own because I just want to see the interest level. So you will not believe he went to the Theta And
Sir,
what
do they
Hakim
get
does,
cured there?
no, this is progressing. They again back to us when they are about to
Yes,
die.
sir.
Their negatives and then there's too much thrust. There's a
So this is
bleeding.
this
So
is the
they again
mindset
came
that
to us.
needs to change.
Yeah, they are just afraid of the surgery, but they are not afraid of anything. Even the Hakim is charging 22,000 per injection. So will you believe for every patient
Too
he
much.
gave the injection of the steroids and ceftriaxone injection, and he also did the padai and durud. So
Ya
he
Allah.
is charging 22,000. Again, people are going every week there and they are losing money, and without getting, there's no improvement, even not 1%.
So, sir, this is merely lack of awareness. Okay, sir, we have another question. What is the percentage of geographic tongue cancers?
Age of geographic tongue, there are two different terms. So geographic tongue is a different condition that is totally innocuous and
Yes, sir.
is not a disease, just erosion of the superficial salivary gland and the papillae. And this is different and it is not cancer. But age of the percentage, age of the geographic tongue, I didn't know this, what you want to ask. Percentage of tongue tumor, there are different percentages in different areas of the world. And tumor of tongue mostly is seen in the patient who is using alcohol with smoking. And even it is common in the oral cancer, in the due to the Putin nut, but it is not that much. What you are asking percentage varies from centers to centers, and what exactly we can't find out and we can't tell you how much percentage of geographic tongue is cancer. So this is, I think, is a level question. If again she can repeat, I will answer it later.
Sir, how often should one go for oral cancer screening, especially if they don't drink or smoke?
Talking about screening.
Yes, sir. Oral cancer screening.
Basically, all cancer screening can be done by the dentist and in any healthcare professional. This it is just starts by looking at the patient inspection. We should look around and there is a marking and marks of the pan gutka thalia patient is using. So again, and after inspection, we should know is there any ulcer in the seven subside. I talked about seven subsides of the oral cavity. Everyone who's anyone who is screening the oral cavity should look at these seven lips, buccal mucosa, retromolophrygone, tongue, flora of mouth, and palate. So these areas should be alveolus of the mandible. Each and every area should be looked for the disease and the lesion and the ulcer. And after even you can palpate with the fingers, and after doing it, then you have to check the neck. Sometimes submucosal masses can be present in the patient. So again, after looking these signs and symptoms, if there is no ulcer, no lesion, no swelling, then patient rarely having the oral cancer, which means patient currently have no sign of the disease. But we can't assure what will happen later.
Sir, how often should one go? Like 4 months or 3 months in a year? कितने time में जाना चाहिए oral cancer screening
At
के लिए?
least,
Usually,
at least one who is using pan gutka thalia, 6 months is the cutoff period, but there is a no standard guideline because every country, developed countries having their own guidelines. But they are recommending 6 months, and but we should recommend same policy as well. But talk about one thing: any ulcer that is not healing in 2 weeks, they should be alarming signs that they should present to us. So if they are following that, I think that is the more appropriate. If they are not witnessing any ulcer and any tumor or any lesion, they should again consult a maxillofacial surgeon every 6 months just for routine checkup.
sir, any new technologies or methods being developed for early detection of oral cancer?
Early detection is only done if patient presents to us in 2 weeks. That's why we are using this formula 2 weeks. Again, there is a question: how do people?
So there's a question, how do we get people to come to clinics and hospitals on appearance of symptoms or ulcers instead of leaving it counts in case of the patient?
No, I said they should visit us every 6 months, and if they have symptom and signs, they should come earlier. And secondly, how? Because patient is afraid of the disease itself. Even if the patient suffering from cancer, he or she do not want to go about the details. They are just doing behavior same as the cat and the pigeon. The pigeon is closing their eyes after looking at the cat, and they are thinking that the cat will not bite them and cat will not eat them. So this is the same with the hide and seek type of things going through the patient mind. And we can just offer free of cost program. We can just offer them a friendly environment to discuss and to come to us and talk about the disease and talk about their relatives that are using these type of substances.
I think we are done with the questions. No more questions, anyone? Anyone wants to ask any other questions? Okay, ji. Thank you so much, sir. We genuinely appreciate the time, effort, and knowledge you shared with us. Sessions like this not only educate us, but also inspire us to take action and help us spread awareness within our communities. Thank you once again, sir, for such a valuable learning experience. Thank you, sir. Thank you, sir. Okay, guys, so our next session is going to start. Just be patient. And such an impressive session it was. Dr. Ismail Maimon's session was so impressive. Uh, we got familiar with so many causes, and I hope now we will help spread awareness within your communities. Dr. Nasik Murray is going to be the host now. And Dr. Numan, are you with us?
Yes, Assalamualaikum ji. Now I can speak, I guess.
Assalamu alaikum. Yes, sir, you are completely audible. And welcome, sir. Dr. Nazik is going to host you now.
Yeah.
Assalamu alaikum. I'm Dr. Nazik Mari, Regional Director, Balochistan at Pride. I'm currently doing my house job at Civil Hospital. It is an honor to be part of this esteemed platform contributing towards meaningful change and regional empowerment. It is an absolute honor to introduce our esteemed guest speaker, Professor Dr. Noman. He is an accomplished oral pathologist currently heading the Oral Pathology Department at QCD. He previously served as the principal and head of department at SMDC Lahore. He is currently pursuing his PhD with a research focus on microRNAs. With over 20 years of clinical experience, he is also the CEO of Dr. Noman Associate Dental Surgeons, and Dr. Noman has numerous national and international publications to his name. He is the president and executive director of Pakistan Society of Oral Pathology and maxillofacial pathology, under which he led the several key academics events. He also served as a deputy regent for Region 24 in International College of Dentists. Today, he will be sharing his insight on reframing histological assessment of OSCC. Let's warmly welcome Dr. Noman Rauf Khan. Dr. Noman, over to you. Thank you.
Assalamu alaikum ji. Thank you so much. And definitely, it's a great pleasure and honor for me to be presenting on this platform, which is a very vigorous and passionate platform. And very happy and proud to see all of you, the youngsters coming forward and doing a great job. I should start sharing my screen. I guess yes. Dr. Nazik, I can share my screen. No? Okay. So let me start with the presentation. Just will ask you if you guys can see the slide, the main slide. I just want to ask if you guys are able to see this slide or not. Okay, so it's a thumbs up. So we can start away with the presentation. Okay, that's good. Thank you. So as you have already heard about me, today I am basically presenting one of my favorite topics, that is reframing histopathological assessment of oral squamous cell carcinoma. Okay, I will be moving the slide. So if at any time you guys are not able to see, I have moved the slide. So please thumbs up if you are able to see the slide has been changed. Dr. Nazik, is the slide changing? Okay, that's great, 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 great. Okay, that's good, 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 good. So as we all know, you guys have already been talking a lot about the oral cancer. We all know that the head and neck cancer, they are arising from the mucosal lining, which is comprising within the head and neck region. I'm actually trying to move the slide, but it's not moving. That's the reason I have also stopped speaking. Uh, Let me see again. So we already know that, okay, there's a lot of changes in the slides. Okay, it's fine. Okay, so we already know that it's a cancer which is been affecting the male population more than that of the females. And among the head and neck cancer, the oral cavity and the lip is the most common anatomical region, and followed by the laryngeal, nasopharyngeal, or oropharyngeal and hypopharyngeal cancers, not only in the USA but worldwide, having the highest incidence rate for the oral cavity and lip cancer, and also the highest mortality rate. One of the local studies I was looking into and was presenting that among the Pakistani population, the buccal mucosa is most commonly affected, followed by the tongue, lower lip, and palate. And among the key factors, the smoking is supposedly the number one factor, followed by the betel quid and smokeless and smoked tobacco. And over the last few years, we observed that there has been slight decline in the incidence of the different oral cavity cancers, but unfortunately, the tongue cancer has been seen to be on the rise. On this world map, you must have been seeing most of the speakers will be sharing this picture with you. It shows a blue stain in different intensities. The higher the intensity shows the higher the incidence rates of the head and neck cancer. And if we look into the map, we can see that the Pakistan has the highest intensity of the head and neck cancers. And other than that, we observe that the viral inclusion has also been affecting the population. And in this case, there is more head and neck cancer among the youngsters who are non-smokers and due to the human papilloma virus infection. So we can see that the oropharyngeal and tonsillar region has been affected by the human papilloma virus and causing the increase in the incidence of the cancer. And with the human papilloma virus positivity, we see it's more among the male also and is also raised over the last few decades. So we observe there is a lot of discussion on the staging of the cancers, and this is, you can say, the my major cornerstone of the cancers, where it has to be determined in terms of its prognostication, its treatment. So the classification is very important. In this case, the American Joint Committee for Cancer Prevention, they have been providing us with the classification and staging for the cancer, different cancers, not only head and neck, but all other cancers. So this is the same suffix we have been studying in the undergrad also. The primary tumor T and the lymph nodes involvement is N and metastasis by M. And this is the oldest classification, which is the seventh edition. And but this classification had some limitation, and there is a lot of long list of the limitation it had. So we'll be discussing them in the coming slides, but limitation have been addressed. So we see that there have been some new clinical pathological variables which have been coming into the play. You guys must have been studying a lot about the new modalities of treatment and new etiological factors. But when we come purely about the head and neck cancer, we do tend to go deep into the histopathology. So we see that there are new clinical pathological features, and they have been seen to be linked with the predictive prognosis of the disease. So the upcoming of the eighth edition has made a paradigm shift in the staging of the head and neck cancers. So what has this staging brought to us? It has discussed about the human papilloma virus and stratification of the oropharyngeal cancers and also the nasopharyngeal cancers, and also some new chapters on the skin cancers, salivary gland cancer, and the mucosal malignancies of the upper aerodigestive tracts. But for us, most importantly, it is basically dealing with the oral cavity cancers and TNM staging for that. So what are the few factors which has been incorporated in the new staging system is the two of the very important variables are the depth of invasion and extranodal extension. There are some other ones also, but these ones are basically affecting the stratification of the staging system. That's why we'll be discussing it today. So we see that there has been a lot of research being going on these variables. About 1400 and plus cases were retrospectively analyzed, and their depth of invasion was studied. And it was seen that with every increase in the 5 millimeter of the depth of invasion, there was increase in the disease-specific mortality. So with this finding and with the relationship of this third dimensional measurement with the occult metastasis and disease-specific survival, it has resulted into the inclusion of the depth of invasion in the T staging of the primary tumors. So depth of invasion, as discussed, is basically with every 5 millimeter increase in the depth of invasion, there is an upgradation in the T stage of the tumor. So in this case, we can see two lines, blue lines and the red lines, but the red lines you can see is marking from the basement membrane to the deepest point of the tumor into the underlying connective tissue, whereas the blue line is marking from the superficial level. Initially, it was a confusion which level should be taken, but now it is clear that it has to be always the basement membrane. We take three different readings, and then we take an average of these three readings to accurately assess the depth of invasion. So how do we do that? We basically mark the entire basement membrane, or you can say the mucosal and submucosal interface, and then we join those lines, and then from the chunk of the tumor, which is extending into the underlying connective tissue, we draw perpendicular to the deepest part of the tumor, and then we measure this in millimeters. And in case of ulcerative tumors, as you can see in this case, you have to go through the ulcerative part. You have to mark two healthier normal mucosa on both the sides, and the central part should be either the main chunk of the tumor, either in the proliferative manner or into the, you can say, endophytic manner, as in this case it's an ulcerative tumor. And then we have to go from 1, 2, and 3 and make a straight line. In case of, you can see, the D, it's basically the nerve bundles being engulfed by the tumor, as you can see in this case. So we have to go to the deepest part, and which is this nerve in this case, and do the measurement. However, there has been some cases where it has been a bit difficult for the histopathologist even today to mark the depth of invasion accurately. And specifically in this case, as you can see, the whole tongue, this is the left lobectomy specimen of the tongue, which basically is showing the intact epithelium all around, and you cannot make out from where to take the depth of invasion. So in this case, you have to very sharply observe the entire epithelial lining, and specifically in this case, you can see the plus sign is given on the dorsal surface. Onto the lateral surface is this exclamation mark, and this minus mark is on the ventral surface or close to the floor of the mouth. So if we closely assess the entire epithelium, we observe that at the exclamation mark, there is dysplastic change in the epithelium. So from the dysplastic changes of the epithelium, we will then go for the tumor measurement. Why in this case? Because we don't see any continuity of the tumor being starting from the epithelium directly, as in other cases we normally see. In this case, we see no link of the underlying tumor with the overlying epithelium. So once again, from the exclamation mark, we'll draw a perpendicular to the deepest part to measure the depth of invasion. One of the another phenomena for depth of invasion is when to add or when not to add into the tumor main chunk. As in this case or in any other case, there can be an extension of a tumor to the deepest part into the submucosa as a result of the lymphovascular invasion. As in this case, as you can see in this picture, in the C, we can observe this is the vascular channel and having this emboli of tumor inside it. So it is about, you can see 6.5 millimeter away from the main tumor bed. So if we look at the main tumor bed, it will be designated as a stage 1 tumor, PT1, as it has a depth of invasion of only 4.5 millimeter. But if we look at the deepest part, it is at least 11 millimeter away from the basement membrane. So it will be then classified as PT3. So this is one of the another trickiest finding in the oral cancer histopathology. So the histopathologists still find it difficult, but in this case, there has been a basic rule, and that is if see that the deepest part of the tumor is more than 5 millimeter away from the lowest part of the main tumor bed, then we do not add it to the main one. So in this case, the tumor is basically PT1. So there is another thing, which is the tumor thickness should not be confused with the depth of invasion, as the tumor thickness is basically the entire tumor mass, either from the ulcerative bed to the deepest part or from the outer proliferative end towards the deepest part. But it is not as that of the depth of invasion, as you can see in this case, picture A and B. In case of picture A, it's a proliferative tumor, and the blue line basically identifies the tumor thickness, whereas the red line, it signifies the depth of invasion. Once again, we are measuring from the basement membrane level, and in this case, the tumor thickness is over exaggerating the tumor properties, whereas the depth of invasion is accurately assessing the tumor nature. In case of picture B, you can see the tumor thickness has been reduced as it has been taken from the bed of the tumor towards the deepest part, but the depth of invasion will be always taken from the basement membrane level. So the depth of invasion will be accurately assessing the tumor nature, and the tumor thickness will be giving us the negative impression. So as we discussed, depth invasion has been incorporated in the staging system, and we see if there is 5 millimeter of depth invasion, it will be T1, 6 to 10, T2, and more than 10 it will be T3. And then we go for the staging. It is T1 till T4. We will discuss that. As in this case, you can see this is the primary tumor staging system being given full description in front of you. But we have done few things, that we have removed some flaws from the previous classification system, and what that was, In the previous classification system, it was more stagnant, it was more static, it was only measuring the superficially the tumor, but not into the three dimension, the depth of invasion. So in that case, there had some flaws like minimal superficial component were there, and then the tumor were seemed to be deeply invading into underlying muscular structure and other structures. So what we have done is that the deeply invested tumor with minimal superficial component were likely to be understaged, and then new AGCs eliminated the extensive muscle invasion from stage 4 of the oral tongue cancer. So every superficial tumor can invade the extrinsic muscle of the tongue. So that's why the new classification has basically removed both of these flaws within the previous classification. Next very important variable, as we are discussing only the two variables today, and if you want to go for further details, we'll do that in some other lectures. Extranodal extension. The lymph nodes has a capsular wall, and if the tumor it tends to invade these capsules and then tends to come out of this capsular wall, we say that it's an extranodal extension. And this is also one of the very important variables and has been and can be seen clinically also, radiographically, and also histopathologically. So, and has been seen to be having a close relationship with the local regional recurrence, metastasis, and disease survival. And therefore, it has been included in both the clinical and pathological AGCC latest edition. As you can see in this case, and if I just summarize it, if you look at the N3, you will see that there is in the older classification only given up to node having greater than 6 centimeter, but in this case we see if it is greater than 3 and with extra nodal extension positive, then we go for 3B. And then if it is greater than 6 but nodal extension, then it is 3A. So the 3 has been further subdivided into 3A and 3B. So it can be otherwise multiple ipsilateral, contralateral, bilateral nodes involvement with extranodal extension, or single contralateral with extranodal extension, all goes into the 3B category. So this is how we look into the lymph nodes. The neck is, full of the lymph nodes in different areas. It has been divided into different triangles. The submental triangle into level 1A and B, and then we go to posterior triangle level 2, 2A and 2B, and then into the sternocleidomastoid muscles. It is 3, and above it is 4, and behind it is 5, which is further divided into 5A and 5B. So this is how we see the lymph nodes involvement, and a very beautiful picture has been shown over here where any size, and if tumor is trying to come out of the capsular wall, it is external extension positive. So some of the pictures, and then there is also there's a pharyngeal carcinoma which has been further classified in this latest classification in clinical classification and pathological classification, and it has been divided on the basis of uh, human papilloma virus positivity. So the stage 4 has been further stratified into three types. It can be for A, B, and C. If it is surgical resectable or unresectable, or it has distant metastasized, depending upon that feature, it has been further classified. So we see that there has been some recommendation for oropharyngeal cancer also in this latest classification system, which includes the human papilloma virus positivity, and it has given both clinical system and pathological system. And along with that, there is immunohistochemistry also involved, which includes P16 overexpression for the nasopharyngeal cancers. As you can see in this case, in the last column, you will see human papillomavirus oropharyngeal cancer. It includes the P16 positivity also. And then clinical staging and pathological staging has also been included in this case. So what we will discuss is that the latest classification is more accurate, sensitive for staging and prognostication of head and neck cancer. And then there is also a point of discussion which is very important, which is the radiographic depth of invasion, which is like pre-treatment assessment of the depth of invasion, which can be done through a radiographical MRI or CT scan. And that helps us if the length of the depth of invasion radiographically we assess is greater than 10 millimeter, then we prematurely tell the patient that we will be going for the neck dissection. However, most of the surgeons in the latest practices are going for the elective neck dissection irrespective of the staging system. But in the literature, it has shown that if you go for the neck dissection irrespective of the stage, it would be better. But some of the surgeons, they go for the neck dissection only in stage 3 and 4 cases. However, there is a proof in the literature which shows that if the tumor is stage 3 and 4, go for a primary surgery direct rather than going for any adjunct chemoradiotherapy. And if it is in stage 3 and 4, you can later plan adjunct radiochemotherapy also. So human papilloma virus, basically we have discussed that there has been classified on the basis of it has been classified into clinical staging and pathological stages. However, the clinical stage is basically based on you can say the nodal staging, but in case of pathological staging, it has been basically more related with the number of the lymph nodes involved. So what we conclude is that depth and variant is now being used to better discriminate the oral cavity cancers, and human papilloma virus with P16 and oropharyngeal cancer is now staged by using a novel system with much better predictive capability. Nodal disease is further refined by the involvement of the external nodal extension. So it's very important for the oncologist to understand these modifications for accurate data collection and patient stratification so that new treatment paradigms can be better determined through clinical trials. In the end, we will say that this latest stage is providing us more precise staging system for oral cavity cancer, particularly for the early stage tumors. There has been improved accuracy in the prognostic staging by incorporating the depth of Bayesian external nodal extension, and it reflects the latest advancement in understanding of the oral cavity cancer. And patient with oral squamous cell carcinoma can be better classified in relation to the overall survival and disease-specific survival while maintaining the simplicity and ease of use of this classification. So, but at the same time, when I'm telling you that this is the latest classification, there is the ninth also classification or ninth edition. But with these upcoming latest classification, they are no more given the term classification. Now they are called versions. So there has been little bit of amendments being going on, being done by the American Joint Committee for Cancer Prevention, and they are now giving them different versions. For example, a little bit of changes were done in the oral cavity tumor, which was incorporated in June, and you can say it was in the lab in 2024 March, which is exactly last year, 1 year back. But there has been slight bit of modifications, but it said that you can continue to use the 8th edition till proper ninth edition is released. Otherwise, these little bit of versions will be coming up with the passage of time. So we will continue to use the 8th edition with little ramification and modification in the versions. So my interest was in this all AGCC latest classification was as a result of my research work on the oral cancer patients, and I use this classification for a stratification and assessment of all the variables. You can look on to the Google and see the article if you're interested. So these are the reference. Thank you so much. That's all from my side. Any questions?
Thank you so much, sir, for this insightful session and presentation. Amazing. We have some questions in the chat.
Yeah, sure.
Dr. Laiba Patma is asking, is depth of invasion the same as T in TNM staging?
Yeah, that's very good question. You see, this T is still being used in the current classification, but it is now used along with the depth of invasion. So it's not the same. It's basically the tumor size. It is measured superficially. The tumor is measured superficially and it's measured in centimeters, whereas the depth of invasion is measured in millimeters. So it is you can see the two-dimensional measurement of the tumor, whereas the depth of invasion is the three-dimensional. You go deep into the tumor bed to measure its extent into the underlying connective tissue. So this is a different. That's a good question.
Also, she asked to repeat the concept of depth of invasion again.
Ah, okay. The depth of invasion is basically the vertical extension of the tumor into the underlying bed. So how do you assess it? You basically go through the entire slide, and there will be an area in the slide where you will see the tumor is going deeper into the underlying connective tissue. So we will only focus on that in that area, and we'll connect a line with the you can say the adjacent normal mucosa where there is the normal mucosa, or you can say a dysplastic mucosa. So the both end of the normal mucosa will be connected, which will be basically in having a tumor bed within its center. So while connecting that line connected, and then from the center part to the deepest part of the tumor extension, you go to look vertically down how deeper the tumor has gone. So this is the just a vague way of measuring the depth of invasion. Otherwise, it's a very tricky and difficult thing to do it on the microscope. But this is how it is.
Okay. Dr. Bisma Jamil is asking, how much can exfoliative cytology be used to determine if a biopsy should be conducted in a patient who is hesitant to go for it with just clinical diagnosis?
You see, exfoliative cytology is basically very helpful in many cases, specifically in tumors where they are located in an areas like in the neck, where there are very important anatomical structures and nerves being passing by and the blood vessels there. So it's actually a very dangerous to go for any cutting in that area initially if the tumor is not properly been diagnosed or not been known. So we go for the exfoliative cytology in that case. But if you say if it can be compared with the true cut biopsy, that is definitely not the case because the biopsy still stands as a gold standard for assessing the nature of the tumor.
How can we improve our histological interpretation skills as dental researchers for case reports, for example, without formal degree in oral pathology?
Uh, that's that's also once again very good question. You see, for every skill acquiring, you have to go through the basics. So if you want to go for histological interpretation skills, you definitely have to go a bit onto the basics. Firstly is the understanding of the basic morphology and the basic histology of the cells and the body parts and the tissues, which is very important. And then if you want to go for some like analysis of the tumors, you have to go through the chunk of the slides, but should always keep some mentor with you, keep some senior with you, and then over the time you will start feeling that you are learning a lot. Because if you feel like you can do it alone by looking at YouTubes or through going through the book, that's not possible. That's why there is a training format in every part of the world where you are been trained as an postgraduate trainee and student, and then you come across some skills by which you are able to do this histological reporting properly.
Sir, is there any role of AI or digital pathology evolving in the staging process?
Yeah, a lot of work has been done on AI and histological assessment, and it is currently underway. And some of the you can say part of the histopathology in some body parts, it has been, you can say, to some extent been covered by the AI. In terms of the oral cancers, or you can say oral cavity lesions, the work is still underway, and I'm sure in coming years there is a greater possibility that you will see a major role of AI in determining or diagnosing the oral lesions.
How effective is the PET scan versus MRI, CT in staging and planning treatment?
It's very effective, very effective. You see, PET scan is basically to the radio emission system, it is directly identifying the lesion within the body. Whereas in case of MRI and CT scan, you have to study those MRI and CT scans, and also they are very effective. Both of them are very effective, but PET scan definitely supersedes the MRI and CT scan. Definitely more effective.
I will, okay, Dr. Visma is thanking you for answering her question. And also, she says, I will also like to ask what your favorite books or YouTube channel for helping grasping the basic is.
That's a very good question, Visma. You see, if you go through your local books, like your textbooks, they are more than sufficient. I tell you honestly, they're more than sufficient. But if you really want to go deep into the histopathology or knowledge, there is no limit to it. But one standard book, Neville, is one standard book. If you study Neville, I guess it's like one big book, and if you are able to even get through Neville, you will be able to do PhD in ornithology. So there are a lot of books, but if you are able to do contemporary and Neville, you can master all oral pathology.
Okay. Dr. Bisma, I hope you got your answer. I think we are done with the question answer thing. That's all for today. Okay, thank you so much for such an insightful and well-deserved session, sir. Oral cancer histological staging. You explain a complex topic in a way that was clear and easy to follow. Thank you so much, sir,
Most welcome, most
for
welcome.
your
Thank you very
time
much.
and dedication. Thank you so much.
Thank you all, and thank you, Pride, for making this platform and bringing many people from different part of the country together. Thank you so much. Allah Hafiz.
Guys, we've shared the feedback form and the data collection form in the chat. Please fill it. Okay, so here's the thing. We will be assessing the participants through the data collection form. अगर आपने data collection form fill किया है, we will have your names on it. तो फिर आपको easily certificates मिल जाएंगे. Guys, this was the schedule for our symposium. Dr. Saman, thank you for sharing.
You're welcome, Dr. Tuba. Assalamu alaikum and a very good evening, everyone. I'm extremely grateful to my dear audience for attending this symposium and truly honored to have esteemed speakers for their insightful sessions. I'm Dr. Saman Sultan, and I'll be your host for today's event on topic TNM 8th edition staging in oral squamous carcinoma, a diagnostic perspective. It is my absolute honor to introduce our distinguished speaker for today, Dr. Komal Shahzad, an accomplished oral and maxillofacial surgeon known not only for her clinical expertise but also for her passion for research, healthcare management, and lifelong learning. Dr. Komal is a position holder graduate of Dow University. She holds a master's in healthcare management from Ziauddin University and a CPS in oral and maxillofacial surgery and a diploma in implantology. Beyond clinical excellence, Dr. Komal has been a prominent public speaker representing Ziauddin University at PCOMs 2024 and 2025. Her commitment to professional growth extends globally. She has completed specialized training in zygomatic implants in Turkey and is an active member of both AO, CMF, and the Canadian Association of Medical Aesthetics. Currently practicing in Karachi, Dr. Komal continues to seek out new challenges, always eager to push the boundaries of her profession and contribute meaningfully to the field of oral and maxillofacial surgery. We are truly privileged to have you with us today, Dr. Komal. I now invite you to kindly take the stage and share your valuable insights with us. Please, Dr. Komal. Thank you.
Thank you, Dr. Saman. Good evening, everybody. I'm Dr. Komal. Today, I'll be sharing with you a very important topic, that is the TNM 8th edition staging in oral squamous cell carcinoma, a diagnostic perspective. I hope I'm audible to all of you. So,
Yes,
today's
Dr. Komal.
presentation. All right, thank you. I'll walk you through the introduction, cancer staging. We'll discuss a bit about the TNM 8th edition classification, key changes that have been made in this edition, the prognostic staging, and a case review. By the end of this presentation, I hope you'll be able to review this edition yourself, including the components of TNM relevant to the squamous cell carcinoma, to understand the diagnostic criteria behind this staging, and to highlight the differences from the 7th edition. Now, we all are aware, and we have discussed this so many times, that squamous cell carcinoma is the most common oral cavity tumor. Worldwide, it has been a burden to all of us. So, most important step for squamous cell carcinoma is its diagnostics, staging, and the treatment planning. Now, all these three steps brings us to the TNM classification, which is the topic of discussion today. It was presented by the American Joint Committee on Cancer. The latest edition, which is the 8th edition, it was published in 2016, which is what the focus of this presentation is. It consists of three parameters: P for tumor, N for node, and M for metastasis. Now, first important concept here is grading versus staging. Now, what is grading a tumor and what is staging? So, grading consists of evaluating the aggressiveness of the cancer cells, whereas staging constitutes understanding its spread. Meaning, if I say there's a tumor that is locally aggressive and involving different layers of the tissue, I would say that I'm basically grading the tumor, which can be graded as well differentiated, moderately differentiated, or poorly differentiated. The word differentiation here means how closely the cancer cell resemble the normal tissues of the body. If I say it's well differentiated, it means it resembles closely the cells of our human body, and hence it will respond better to the treatment, better to the chemo, and better to the radiotherapy. Whereas when we talk about staging, where here which is the process of determining the extent to which a tumor has developed, this is where TNM comes into play. Now, the cancer staging, it can be stage 1, 2, 3, 4, depending on the level of differentiation of the cells that I've already mentioned. Stage 1 being a localized tumor, whereas stage 4 having spread to various parts of the body, in other terms known as it has metastasized. Now, so cancer staging, it takes into account generally three things. Number one, the tumor itself. Number two, whether the tumor has invaded any adjacent organs or lymph nodes. And number three, whether it has appeared in any more distant locations of the body. Moving further, why is this staging so important for diagnosis and clinical assessment? Firstly, it defines the extent of the disease, meaning if there is a tumor somewhere on the lateral or border of the tongue, so it will tell us whether that tumor is involving the underlying muscle, the underlying floor of the mouth, or the bone. So it will find the extent of disease. Second, it guides diagnostic focus, meaning it'll help us decide on the diagnostic tools that we need to use. Like, for example, MRI is more suitable when there's soft tissue invasion, and CT scans are used when there's bone involvement. Whereas a PET scan is used when you're suspecting metastasis in different organs of the body. It also stratifies patient clearly. When you're able to stage the patients clearly, we'll be able to evaluate them properly and then plan treatment accordingly with the help of the tumor boards. It also improves interdisciplinary communication. For example, instead of me telling a radiologist that it's a 2 by 2 centimeter tumor, which is invading 15 mm of the bone, etc., I could just say it's stage 2 tumor. So it helps with communication. And lastly, it reduces under or overestimation. It will prevent under treatment of an aggressive disease and over treatment of an early or a less invasive tumor. Now, the key changes in 8th edition versus the 7th edition. The first change, introduction of depth of invasion, as was already discussed. This depth of invasion is defined as distance from the level of basement membrane of the adjacent normal tissues to the deepest point of tumor invasion. We'll be discussing it further in the upcoming slides. Second, inclusion of extranodal extension, meaning a tumor extending beyond the margins of the lymph node. And lastly, the clinical versus pathological staging. The first point, depth of invasion. As I mentioned, it is the distance from the level of basement membrane to the deepest point of tumor. Then what is tumor thickness? It is measured from the top of the tumor to the deepest tumor cells. If you look here at this figure, you see a white arrow extending from the basement membrane till the largest point of its invasion. This is depth of invasion. Whereas tumor thickness is the entire thickness of the tumor, which is extending beyond the normal tissues or the normal oral mucosa. Here again, the gray area that you see here is the tumor, irrespective of if it's an endophytic tumor or an exophytic tumor, as you can see in this figure A and B. If you look at figure A, you see that the distance from the basement membrane to the deepest point of invasion is greater when compared with the figure B. So even though you see that tumor B is a larger tumor compared to the figure A, still it has a less depth of invasion compared to the above figure. Hence, we can clearly say that tumor A is more aggressive. So it's not primarily the size of the tumor, but it's the depth of invasion that classifies the tumor and talks about the prognosis and the treatment plan. Coming to the extranodal extension. In simple terms, extension or growth of the cells beyond the boundaries of the lymph node into the surrounding tissue is what the extranodal extension is. Why is it important? It's because having an extranodal extension positivity is a sign of an aggressive tumor and associated with high risk of recurrence. Here we'll see the clinical significance of these two additions in the 8th edition of TNM. As I mentioned, DOI, which is depth of invasion, it signifies an increased risk of metastasis and local recurrence. It indicates the tumor aggressiveness and plays a critical role in surgical planning and the extent of resection, meaning the surgery that we need to perform. Whereas extranodal extension, it refers to a poor outcome of the tumor and it alters the nodal staging, which we'll discuss in the upcoming slides. And also it is very important for the subcategories of N, which is node. Third point is clinical versus pathological staging. This was added in the N staging of TNM. Now the difference here is clinical staging is when the patient has not undergone any surgery. It's the patient has presented to us in the OPD or the clinic, and we are evaluating the patient based on the history, his symptoms, physical examination of the patient, or if we have any radiographs, CT scans that we have done, if we have any FNAC that we have performed for a node, and it's simple evaluation of the patient, or also if there's biopsy that we have done. Anything that happens before the treatment and how we stage is known as clinical staging. Whereas pathological staging is when we have performed a definitive treatment, meaning we have performed the surgery, we have taken out the tumor, we have sent the tumor to the lab, and now the lab is giving us more insight on the pathology of the resected specimen. That is your pathological staging. Here, you'll see the differences from the 7th to the 8th edition. First off, the basic difference is the removal of P naught in the 8th edition, which is the no evidence of primary tumor. Tumor staging basically starts with a tumor which is less than or equal to 2 centimeter, 2 to 4 centimeter, and greater than 4 centimeter. Now, in the 8th edition, you'll see with these tumor sizes, there's also inclusion of depth of invasion, which starts from less than 5 mm, moves on to 5 to 10 mm, and greater than 10 mm. So if suppose I say there's a tumor which measures only 2 centimeter, you'll suspect it's T1, but no. If it has a depth of invasion greater than 10 mm, even though it's a very small tumor, but it will be staged in T3 because it has a greater depth of invasion. So depth of invasion holds a greater value when staging the tumor compared to the tumor size alone. This is again the same classification. Okay, now coming to the nodal staging. Nodal stage, this is the clinical staging. Nodal staging starts with the lymph node size 3 centimeter or smaller, N2 3 to 6 centimeter, and N3 greater than 6 centimeter. Here, these are the subcategories that I was talking about. You see here, N2 is further subclassified into 2A, 2B, and 2C. 2C. Difference is not the size, but the location. You'll see N2A is a single ipsilateral lymph node, whereas N2B, multiple ipsilateral nodes, N2C, bilateral or contralateral node. In N3, it's further subclassified as 3A and 3B. Here, this is classified on the basis of extranodal extension positivity. You see, a tumor is lymph node is greater than 6 centimeter with ENA negative is 3A, whereas a tumor with ENA positive is N3B. This is the clinical staging. Now the pathological, which comes to us after the treatment and from the final specimen of the tumor. Difference here is in N2A. Here you see we have discussed that tumor node should be 3 to 6 centimeter. But if a tumor node is 3 centimeter or smaller, but has ENE positivity, it will go directly into 2A instead of N1 that it should be. Similarly, another difference in pathological staging is here in 3B. If the tumor is larger than 3 centimeter, but has ENE positivity, it goes into 3B instead of N2 that it would generally go. So these are the basic differences and additions in this classification with respect to the oral cavity tumors only. Now, this is the further differentiation that we have discussed. You see, in the 7th edition, N3 wasn't classified into further N3A and B, but with the addition of ENE, it has been further classified as 3A and 3B. Now, all these TNM's classification helps us to stage the tumor. How? T1, stage 1 tumor. T2, stage 2. Difference arises with stage 3. As soon as you see a positive N1 level node, it goes straight away into stage 3, whether it's T1 or T2. Similarly, if a node is N2, it goes straight in stage 4A. N3 goes in stage 4B. And what is stage 4C? Any T, meaning any size, any DOI, any nodal staging, but with metastasis, M1. Metastasis in any part of the body, irrespective of the size of the tumor, goes straight away into 4C, having the worst prognosis. Now, we'll look at this small case here to have a better understanding. This was a 58-year-old male, a chronic tobacco chewer. You see here 2.5 centimeter tumor lesion present on the lateral border of the tongue, no distant metastasis. MRI indicates a depth of invasion of 9 mm, no involvement of bone. And in the neck, we see level 2 node positive with 3.2 centimeter and ENE positivity. According to this new addition, tumor goes straight into T2 based on the depth of invasion, N3B because of the ENE positivity, and greater than 3 centimeter. This staged the tumor as stage 4B, having worse prognosis. Now, this is how it's presented on a histopathology report. For you to look, here is the tumor size. Here you can see that all 3 dimensions of the tumor are mentioned. When we stage the tumor according to TNM, we use the greatest dimension, which is 4.6 over here. Similarly, you can see depth of invasion is mentioned here. And also, it is mentioning the extent of the disease that is involving the overlying skin and the underlying bone. Similarly, all the notes that you send for histopathology will be displayed individually on the histopathology report. For you to note over here is the extranodal extension, which is present here in this patient. So this new TNM staging has been validated numerous times in multiple studies. And you can see here that all the patients who were previously classified in T1 or T2 staging had been uh, reclassified. Here, as you can see as an example, T1, after the addition of after the 8th edition, 7 of these T1 patients moved on to stage T2. This is based on, of course, the DOI, addition of the depth of invasion. Another interesting concept I would mention before ending my presentation is the worst pattern of invasion. Now, this worst pattern of invasion was included in the AGCC classification and is currently irrespective of the staging. What it tells us is the microscopic spread of a tumor beyond the gross disease at the tumor and tissue interface. It's mostly important for occult nodal diseases. Occult nodal diseases meaning you were not able to palpate any nodes when the patient presented to you in the clinic, right? So, according to agencies, okay, this is the classification stage 1, 2, 3, 4, 5. Here, what is important to us is the worst pattern of invasion number 5. This is what AGCC focuses on. It consists of tumor satellites which lie 1 mm or more away from the main tumor. Why is this important? Because AGCC identified 87.8% of the T3 or T4 tumors of the buccal mucosa, they had worst pattern of invasion of 4 or 5. Hence, this became an important criteria and a very important histopathological grading system to predict which low stage patients are at a significant risk of local regional recurrences, and to further implement adjuvant therapies that can be directed to save such patients and can be individualized, getting individualized treatments and management based on this. So again, you can see this worst pattern of invasion increases as the depth of invasion increases, further worsening the disease in other terms. So to summarize, we have already discussed this worst pattern of invasion. Now, the eighth edition of TNM has marked a pivotal shift in how a tumor is staged, with the addition of course, depth of invasion and extranodal extension. It marks the accuracy of staging, early risk identification, provides a very detailed understanding of the tumor behavior for a surgeon, especially, and it's also very effective for clear communication among the clinician. So, as a take home message, know the criteria, understand the impact, and apply it consistently. Thank you very much for your time.
Thank you very much, Dr. Komal, for the enlightening session. It was very informative. Your slides were so beautifully made. I now request the audience to kindly feel free to share your questions and comments related to the topic. You may write them in the chat box and Dr. Komal will respond accordingly. So, ma'am, we have some questions for you.
Yes.
Ma'am, everybody is actually appreciating your slides and information. You were very eloquent and the presentation was very good. Thank you very much for your time and information.
Thank you so much, everyone.
So, ma'am, we have the questions now.
Yes.
Dr. Shanzit Kaleem is asking, what if the spread of the cancer cells is more aggressive towards the width than depth of the normal tissue? In that case, according to DOI, will it be classified in the less aggressive criteria?
Okay, here, when we're talking about spread of tumor, it's obviously not in one dimension. The tumor spreads in 3 dimensions, right? So when we're looking at the tumor from a clinical perspective, as a clinician in the OPD, if you're looking at the tumor, you'll only be able to see what is beyond the normal oral mucosa. You might see an ulcerative lesion. You might see an exophytic small cauliflower-like growth, right? But that will not be sufficient for you to stage a tumor, right? For the staging, for proper staging, I would say, you would need additional information, which is CT scan or MRI, correct? So when you see a CT scan or MRI, of course you see the size of the tumor, but you would also see the depth. Depth is what will classify the tumor, and depth is what will tell you the aggressiveness of the disease. No matter if the tumor you see on the oral cavity is approximately 4 to 5 centimeter, of course it's a big tumor. But if it has a depth of invasion of only 2 mm, for suppose, it will be less aggressive. Why? Because it has still not invaded the underlying structures yet. Depth of invasion means how far the tumor is going beyond the actual disease that we see. So if it's not extending further beyond into the muscles or into the bone, that means it is less aggressive. So that's why it is used as the criteria.
All right, ma'am. Thank you so much. I hope, Dr. Shanzi, your concept is clear now. Dr. Ghazala is asking, how do you see the role of pathologist and radiologist evolving in light of these new staging criteria?
Yes, here it is very important. Why? Because once we have performed the surgery, that is only step one of the treatment. The further treatment starts with chemo and radiotherapies. Of course, first, okay, let's talk about the pathologist first. What the pathologist will do, it will tell us the size of the tumor. And now he or she can tell us the depth of invasion, which was not initially checked when we didn't have the eighth edition criteria. Even if a pathologist would tell me it has a depth of invasion of 5 mm, I wouldn't know where to classify it unless and until I have this eighth edition of classification. Correct? And for the radiologist, I need to communicate to the radiologist that, see, it has a depth of invasion of 10 mm or more, meaning it is in stage 4. It is a very aggressive tumor. That means That is how the radiotherapist is going to plan the post-op radiation of the patient. Correct? Because surgery is just the first part. Next step is radio, next step is chemo. So the radiologist needs to know how further the tumor has spread. So accordingly, he can plan the number of sessions for the patient. And similarly, the chemotherapist can decide on the number of drugs and the number of chemo radiation the patient requires.
Thank you very much, Dr. Komal, for an elaborative answer. Dr. Harim has a question. What is the difference between treatment of different stages? Basically, how is treatment of stage 3 different from that of stage 4?
Okay. If you might have seen in my presentation, stage 4, okay, stage 3 is a tumor that we have already discussed. Size having greater than 4 centimeter, the first point. Second point, depth of invasion greater than 10 mm. Now, what is the difference between T3 and T4? T4 is a tumor that is extending further beyond the structures, meaning if I have a tumor on the buccal mucosa of a patient and I see that it has extensions and going above somewhere into the maxillary sinus, the infratemporal fossa, meaning extending from its localized structure, not just like muscles or tissue, that is something else, that is based on DOI, but extending into other structures like going into the maxillary sinus or maybe extending beyond into the base of the skull. That is what will differentiate T3 from T4. And sometimes when a tumor is that aggressive, going like, for example, going into the base of skull, surgery is not even possible. So that is how we differentiate based on the treatment. Okay, yes, T3 is a treatable tumor, but if it's a T4 tumor involving okay, for example, the carotid artery or involving the base of the skull, then I cannot go into the skull to remove that tumor. I would just send the patient for a radio or chemo session. That's how we differentiate it.
Thank you so much, Dr. Komal, once again. Ma'am, Dr. Paris is complimenting very clear voice and very impressive speed of presentation, which is very helpful for us in gaining and understanding. Thank you so much, Dr. Komal, for this. And ma'am, I have a question.
Yes.
What advice would you give to postgraduate students or early career clinicians for correctly applying the TNM 8th edition in their clinical practice?
Talking from my experience, it was very difficult for us to literally memorize this TNM classification in the early stages. So my advice would only be starting from day one, whenever you receive such a patient, no matter who is treating it, even if your seniors are looking after it, just sit around and classify that tumor based on the TNM. Start from day one. If you start practicing from day one, you'll be able to memorize it and apply it clinically more effectively than I would say myself too, because it was very difficult for me to memorize it myself.
All right, ma'am, we have just another question from Dr. Tuba. How does the TNM stage influence treatment decisions? How and are they absolutely correct?
Okay. About being them correct, I guess we'll have to believe it since the correction, the new additions, they come from a lot of years of researches. So I'm sure we need to accept that. As for the treatment, I would say, yes, TNM influences the treatment decision because once you'll classify the tumor based on the TNM, you'll know if it's stage 1 tumor, stage 2, stage 3, or stage 4. And yes, that will affect your treatment. How? Because if it's just a very small stage 1 tumor, you know it's not locally aggressive, you can just remove it in a very short 1 hour procedure. But if it's a tumor that is stage 3, this would mean that it is involving the lymph nodes. It might also be having extranodal extension positivity. That requires not just the removal of the tumor, but also the removal of the lymph nodes, along with any structure that is involved. So, yes, this will affect the treatment decision because we'll need to be going for a more aggressive approach. We can't, protect when we're doing surgery, we can't decide, okay, let's protect this structure or that. We need to remove the entire tumor, no matter if we are removing half of the patient's face, because the tumor needs to go.
Thank you, ma'am. And last, I think this is another question by Dr. Hajra.
Yes.
What new treatments or clinical trials are showing promise for oral tumors? How is AI or technology being used in diagnosing or treating oral cancers?
Okay, for AI, as far as AI is concerned, AI helps in, even though it's not widely being implemented at this moment, I would say, but still, for us here, when we are talking about diagnosing a tumor, we have 3D tools as well. We look at the tumor from a 3D perspective on our scans, on our laptops, and on our softwares. So there AI comes into play because it will be able to guide us and better tell us the boundary of the tumor. It helps us to better stage the tumor, even though currently in Pakistan, if I'm talking, it is not being implemented widely for tumor surgeries at the moment. Worldwide, yes, of course, but not in Pakistan. But yes, as far as I'm concerned, and what we do is it helps us in staging the tumor when we are using various softwares, the AI softwares that we use, which tells us clearly in 3 dimension. We can move the skull around on those softwares and see how far that tumor has spread. As for the new treatments you're talking about, okay, for the new treatments, yes, radiotherapy is making some advancement, but when in terms of surgery, surgery always stays the primary mode of treatment in tumors, but we are also moving on to genetics. That is the new treatment, and that is what the clinical trials are being conducted on these tumors. Why? Genomic study will help us detect the tumor at a very, very early, and I would say at the birth of the tumor, we'll be able to identify it. And then we can stop the gene there and then. Instead of, the patient going, because patient go it's not just the patient, it also the family that goes through a lot because of these tumors, and it takes a very stressful toll on the family. So if you're able to identify a tumor at a gene level, yes, there's some change in the gene of the patient that could lead to a very aggressive tumor in the future. Of course, that will change the entire dimension of this tumor management, I would say. I hope I've answered your question, Dr. Hajra.
Thank you so much, Dr. Komal, for such an insightful session and such an informative presentation. I hope the audience is pretty much satisfied with the question answer session. Once again, thank you so much, Dr. Komal, for such an informative session. I would also like to thank the audience for the active participation in today's question and answer session. With this, I conclude my part and hand over the mic to Dr. Harim, who will be continuing further. Thank you so much.
Thank you so much.
Thank you.
Thank you so much, Dr. Suman, and all of the speakers for such an amazing session. I'm Dr. Harim Fatima, and I'm an integral part of the organization team of this symposium as well as Pride. I just want to make sure everybody is enjoying, and I need to tell you that the attendance and the certificates will be marked based on your participation in our forms. Okay. So our next speaker is a dynamic and inspiring force in dental community, a proud graduate of Margalla Health of Institute of Health, and he is a distinction holder in oral medicine. He's a visionary founder and director of both Pride and an initiative dedicated to research, innovation, development, and education and experience dentistry. With 3 published research articles, including 2 in reputable Pakistani journals and 1 in an international journal, he continues to contribute significantly to academic literature. Currently, he is mentoring over 25 research projects under Pride. His leadership and organizational skills shine through his role as chief organizer of Virtual Dental Symposium. Please join me in welcoming ever-inspiring Dr. Muhammad Farooq. Dr. Farooq, please take the mic and stage.
Assalamu alaikum, guys. I hope I'm audible. Dr. Reem, am I audible?
Assalamu alaikum, sir. We welcome you in this symposium. It's a great honor to have you. You are completely audible, clear and audible.
Thank you very much, Dr. Saman, and thank you, Dr. Harim, for a very great introduction. I would just share my slide with you guys. Okay, basically, is it visible, Dr. Harim and Dr.
Yes, sir. Yes, sir, your slide, your screen is visible.
Okay, so guys, starting first of all, I want to appreciate all of you guys who have been here for this symposium. Uh, it's a very great honor for me to be as a guest speaker here as well in the league of basically very great surgeons, oral maxillofacial residents and surgeons, and professors and principal as well. So it's a great honor for me. So let's start our today's session. So my today's session will be basically on emerging diagnostic modalities in oral head and neck cancer. As the term emerging implies, the one which is right now trending right now and is coming up. Okay, so let's discuss this. So today's agenda will be discussing about the traditional diagnostic approaches, the need for emerging, why there is basically a need for emerging modalities, because already there are a lot of traditional diagnostic approaches available for us, and apart from that, there is also point of care devices which are available, and then I will be concluding my session. So let's start with first on the day why we are here. Basically, we are here for the oral head and neck cancer awareness, and you would be very much amazed that oral head and neck cancer is on the rank of 30th topmost world cancer worldwide, and in Pakistan, basically, it's on the second number. It's very shocking. It's basically after breast cancer. So there is a lot of increase in the number of cases of oral head and neck cancer each and every year in Pakistan because of the lifestyle we are having here, and due to the some factors like tobacco usage and fetal nut chewing, etc., Charlie, etc. So early diagnosis basically improves both the survival rates and the quality of life. So it depends upon basically as a on the healthcare professional, because we all are as healthcare professionals. So basically, it's our duty to first diagnose it and then increase the chance of treating it earlier at as much earlier as possible and improving its prognostic factors as well. So whenever a patient comes into your clinic, I would highly suggest, and including me as well, first do a complete diagnostic checkup, and don't don't overlook the lesions, white lesions or other patches you found on the oral cavity, um, on the palate, on the floor of the mouth, on the buccal mucosa. Okay, so these are the some of the sites basically where the white patches and you can say pre-malignant lesions and are very much common. Okay, it could be either oral submucous fibrosis, oral squamous cell carcinoma, etc. So, but your duty as a healthcare professional is to identify it or just use as a to diagnose it basically. Okay, so there are new diagnostic tools that are transforming early in detection in patient care. We are living in an era of AI. So Alhamdulillah, because of that and other some technology advancement, we have some new additional diagnostic approaches as well compared to the old traditional diagnostic approaches which we do in our clinics or hospitals. So what are these traditional diagnostic approaches that we were commonly using earlier? The first one is basically the most common, the clinical examination you do, as I told earlier. Okay, then there is a biopsy that you do. In biopsy, basically you do a inclusive or exclusive biopsy. Okay, and then there is a histopathology. You then send it to the lab for histopathology, as the earlier speakers told about it, TNM staging and other thing doing. Okay, so then we have imaging. So imaging, we have a CT scan available, MRI, magnetic resonance imaging, and PET scan available as well. Okay, so these are the old traditional diagnostic approaches which we commonly use. But what are the limitation we are having it, and what are the drawbacks we are having in them? Okay, the first drawback is that all of these are invasive. Basically, in biopsy, you need to cut a piece of lesion and then send it to the lab. So basically, it is an invasive procedure to be performed on the patient, and some patients are reluctant and don't want that. So due to this factor, basically, they go to the late stage detection, and when the stage is detected of cancer is detected, then there is no time that can be repaused. Okay, so the other one, as I suggested, that late stage detection is available. ठीक है, And then in Pakistan, as you all know, that we are currently developing countries, one of the developing countries. So we are having a lot of financial problems with these expensive tests. Okay, so we are having a lot of cost barrier and cost uh, issues in having such tests available. So as you can see on the left side, there is a picture of a device. It is basically called veloscope, and it is emitting a blue light. Okay, and what it is doing is basically it is emitting blue light on the surface of your skin or surface of your oral mucosa basically. Okay, so what it does is basically it emits blue light, and when the blue light is emitted on the surface of epithelial cells gets disrupted. So uh, it is basically activating them, and after disruption, the cells which are malignant basically, they appear in darker green color. Okay, so darker green color is the sign of uh, malignancy. Okay, and the light green color is basically showing these are normal epithelium cells, as you can see in the picture. If I can just okay, so why is there need for emerging modalities? The need for emerging modalities, as I suggested, because we are having challenges with the traditional methods, as I told earlier. The benefits of uh, the emerging modalities are basically these are non-invasive. Okay, first thing, and they diagnose it earlier. This one, which I suggested, told you earlier, veloscope, it is basically non-invasive technique. You just need to put that device near the uh, patient mouth. It is just like basically you can say that our composite light curing machine. Okay, so like you can place it near the oral mucosa, and then it will show that on which lesion basically on where in the oral mucosa there is a lesion which is showing dark green color. The dark green color will show that it is basically a pre-malignant lesion, and it should be treated as pre-malignant lesion, and it is going towards oral cancer basically. Okay, so then there are some biomarkers, ठीक है, which have made our life easier for detecting the earlier cancer. And with the advancement of technology and AI, you all are familiar that our work is very much easier. So first, I would discuss about the liquid biopsy. Uh, what is basically liquid biopsy? As the word liquid biopsy suggests, basically it is a biopsy which is taken from your blood. Okay, it is basic. It can be taken from other fluids as well, but it is done mainly from the blood. So in blood, what happens basically when you are diagnosed with a cancer, uh, some of the DNA has a rotational has some of the DNA has components which are degraded from the malignant lesion. The malignant lesions basically shed into your circulation, blood circulation, and these fragments are incorporated with your free DNA basically. Okay, the terminologies are mentioned here is cfDNA and ctDNA. Basically, these are the circulating free DNA and circulating tumor DNA. Okay, so in your circulation, basically in your blood, there are fragments of the tumors that are present. So what happens when you do liquid biopsy, you can detect from your blood basically that you are having signs of pre-malignant lesions, or you are having cancer basically. Okay, so what are the advantages? It is a non-invasive. Just you need to take a syringe of blood, okay, and then it basically uh, also allows for the early detection, okay, and then it also helps in your uh, prediction as well as prognosis prediction as well. So a lot of case studies are being done right now in head and neck squamous cell carcinoma, and the liquid biopsy is the most famous one emerging diagnostic modalities which is being used. In Pakistan, basically, we are having some issues because of the financial modalities, financial constraints. Okay, so but all over the world, the liquid biopsy is the first and the favorite right now emerging diagnostic modality which is being used for the treatment of for the detection of oral cancer or any other kind of cancer. So you can you can conceptualize it or understand it better from this picture. So what basically this is a syringe. What we did it in the there was a lesion in the mouth. So some of the fragments dislodged into the blood circulation. And what we did we took a pile of a little bit blood, okay, and then we did a biopsy of it, and we ran some test on it. On in the test, we see that there were cell-free DNA, circulating tumor cells, extra cellular vesicles, microRNA, miRNA. All of these shows basically some of the signs of the uh, detection of cancer. Okay, so you can visualize it from this diagram basically. This is basically taken from a research paper which was published in Elsewhere. So I use it here. Okay. So then there are optical imaging techniques. So one of the most important technique which I will be discussing today, and I have little bit told you guys earlier as well. It is fluorescent imaging technique. So as I told earlier, with this diagram basically, so this is basically for fluorescent imaging technique. The light emitted is basically a fluorescent light. Okay, it's a blue color fluorescent light, and when it appears on the emitted on your surface of the oral mucosa, the green color is appeared. Light green color shows uh, benign, shows no lesion basically. It's normal. Okay, and darker green color shows a sign of malignancy. Okay, so basically it's a fluorescent imaging. ठीक है? It highlights cancerous tissues during the clinical exam, as I just told. Then there is narrow band imaging, enhances visualization of vascular changes linked to the malignancies. It's just like CT scan little bit, but it is visualizing basically the vascular changes in the malignancies. Okay, and optical coherence tomography. It is also uh, technique basically which is microscopic cross-section imaging does it. But these two are very much extensive and broader and not basically available at the Pakistan. So I will be focusing more on the technique which is basically right now in Pakistan and which we can use as a dentist or uh, dental surgeons and home surgeon. Okay, so this is veloscope basically. As you can see with this picture, it is very much visible, and you can get the point that it is basically emitting the blue excitation light. Okay, so what happens when the light is emitting on the surface? All the cells are then disrupted. Some cells are disrupted and show abnormal epithelial cells, and all in such abnormal epithelial cells are basically uh, showing the signs of malignancy. Okay, and then the normal cells are showing just green light. Okay, so this I think with this picture you can visualize it. Okay. Then there is artificial intelligence and machine learning, which is basically the right now the most trending one. But in Pakistan, it is not being right now much introduced on and is not very much being worked on. But it has made the life easier as well. It is analyzing imaging data and is taking the patient history, enhancing diagnostic accuracies. Basically, it is making the work easier for the dentist and other oral surgeons. ठीक है? And it is reducing the human error, which is uh, supposed to happen. Then it supports early detection and treatment planning, basically. So with this picture, you can visualize that AI is playing a role in making your life easier with some making good prognostic predictions. Okay, so these are all the applications which I mentioned earlier: autofluorescence spectrum, veloscope, green light emitting, optical coherence tomography images. Okay, and uh, photographic images, and then histopathology, which is basically our foremost exfoliative cytology images. Okay. Okay, this one is very much important. Why? Because it's also non-invasive and it is very much accessible in Pakistan as well. It doesn't require as much as financially. It is not very expensive. The thing which I mentioned earlier, this is expensive basically. The instrument is expensive. It is around 4,75,000 rupees in Pakistan right now. Veloscope machine. Okay, and I don't think most of the dental institutes or hospitals have it right now. apart from some few. Okay, and clinics don't. I don't think so. Some might people have it. Okay, but it is a very good tool, and it should be in. I think it should be present in each and every institute because it makes the life easier, and it can detect earlier all the preliminary lesion. Okay, so then we are moving towards salivary diagnostic. We have our saliva contains basically biomarkers like DNA, RNA, and protein and metabolites, as you all know. So what we do is we take a saliva swab, and we detect cancer-related biomarkers. Okay? For example, like IL-8, IL-1, and MM9. These all are the biomarkers of basically oral cancer. When you detect these in your saliva, then you are having a lot of chances that you are having a oral cancer. It is also a non-invasive technique, as I suggested. It is easier to collect, and it is cost effective, as I told you, and it has a potential for early stage detection and monitoring. So basically, it makes your life very much easier. Library diagnostics. You can see with this picture. This is also taken from a uh, article published on Elsewhere. So what did they do is they took a swab, then they did a sequencing. And then gene sequencing is basically the one I told you earlier in the liquid biopsy. There are this fragments of DNA. Then they see in it uh, either they are components of circulating tumor factors or not. Okay, so they did the data analysis, and they see either the cells are healthy, or they are benign, or they are malignant. Okay, and then on the basis of that they make a diagnosis and a prognosis as well. So right now the salivary biomarkers which are being used are human DNA and mRNA biomarkers, and protein, actin, and myosin biomarkers. Okay, and some of in some cases circular RNA as well. Okay, but in future there is a lot of promising scope of circular RNAs and non-coding RNAs, which will also help in detecting the oral head and neck cancer detection. Okay, so this is I think the last of our technique, molecular imaging. So PET MRI hybrid system. Basically, it improves soft tissue contrast and metabolic activity mapping. So it is a PET scan, and what it does is there is a targeted radio tracer that are placed and which enhance the specificity to cancer cells. I will tell you in the next slide. It is basically crucial for precise staging and treatment planning. As the speaker earlier told us about a lot about the staging and grading, so it basically help in uh, making it identify very much easier. So in the white light, when a tracer was placed basically on the lesion, it was not very much visible. But when fluorescent light was placed, then it was visible. So you can, as I told you, that fluorescent light plays a very much important role in detection of oral health and cancer. So basically, these techniques also involve fluorescent light, and on the basis of that, then we can do a tumor excision as well. Okay, so point of care devices. Basically, as I told you, the life is easier now. That portable diagnostic tools for clinic are available, and for remote areas as well. Example include handheld fluorescent, the I machinery I suggested, take and Raman spectroscopy, the veloscope basically. And what are basically they are basically rapid. As I told you, they can detect just in 40 to 60 seconds. Okay, just you need to place the light around 20 to 30 seconds, and around 30 to 35 seconds the lesion gets appear. It just takes 10 to 20 seconds for the cells to get activated and disrupt and show the color. So 30 to 40 seconds is enough basically, and you can get early diagnosis. If you just want to take a little bit time, you can take it. It is not very much harmful. You can take 1 or 2 minutes because there are a lot of factors to be considered when you are doing it in the oral cavity. Okay, so and it basically access the cancer screening. Okay, so this is the device. I want you guys to have a look on it, and if you guys want to take a picture, do take it. Why? Because it's a life-saving machine, and it's a portable device. You can easily hold in your hand. You can add your phone as well for the recording, and there is a camera. A camera basically it's a camera as well, including camera along with the photo emitting light. Okay, and this is a power button. You can place it. So again, this is also AI, the role of all the microscope and probes which we can place and detect with the help of cancer. I want you guys to see this video, please.
Oral cancer is the erratic growth of cells that invade and damage surrounding oral tissues. Regular screenings by your dentist or dental hygienist are very important, particularly if you fall into any one of the following high-risk groups: heavy smokers, heavy drinkers, someone who has been exposed to the HPV virus, or men over the age of 45. Oral cancer is being diagnosed in both the throat and the mouth at an increasingly alarming rate due to the prevalence of the human papillomavirus. It is estimated that over 50% of adults will contract this virus in their lifetime. Screening for oral cancer has never been more important. Furthermore, oral cancer and abnormal cell growth begins beneath the surface. By the time we are able to clinically see it, it may be in the later stages. Oral cancer screening is non-invasive and painless. Your dentist or dental hygienist may use a device that emits a particular wavelength of blue light, which excites natural fluorescent molecules in the tissues of the mouth. Healthy tissues fluoresce differently than the tissues that are disrupted by trauma or disease. The device can aid the dentist or dental hygienist in discovering a wide array of abnormalities, often before they are visible to the unassisted eye under white light examination. The screening is very straightforward and begins with a visual inspection of all soft tissue regions inside the mouth. The dental hygienist or dentist may also inspect each side of the jaw, neck, and collarbone for any differences, sensitivities, or growths. Regular screenings will help reduce your chance of any serious infections or cancer from developing. Ask your dentist about today's leading screening device, Velscope, to complement oral cancer screening at your next appointment.
Okay, so with this, I would like to conclude my session. Basically, emerging diagnostic tools offer a hope for earlier and more accurate detection, and its public awareness and healthcare access are the key factors basically to in reducing the oral health and neck cancer mortality. Ongoing research is vital to bring these technologies into the everyday clinical use. I hope you guys might be familiar with it, but if you guys are familiar with it today, and I would highly suggest share it in your circle as well, and ask the people around yourself to include this at least veloscope in their OPDs and in your institutes as well. That will make the life very much easier for you guys. Uh, it's a little bit expensive, I know that, but you can take a step, and your first step would basically help a lot, and it will make a impactful uh, action in the future for the all the kind of the humankind basically. Okay, so with this, my session is concluded. Thank you for listening it, and if you guys have any question, you can let me know. Thank you.
Thank you very much, Dr. Farooq, for an insightful and informative session. We totally appreciate your time and the way you made presentation. It was so informative, very well made. Yes, sir, we do have questions in the chat box for you. Dr. Shanzit
Sure.
is asking, what is the accuracy level of veloscope?
Uh, Dr. Sanjay, basically, what the research suggests, research papers I have read, they are suggesting around 70 to 80. But in Pakistan, it's a little bit, it's early to say how much its efficacy is basically right now. But all across the globe, there is a percentage of 70 to 80% reported.
All right, sir, thank you. I hope, Dr. Shanzeh, the answer is clear to you. Dr. Rubina Shehbaz is asking, what is the time of light exposure to lesion?
Okay, so basically, as I mentioned, when you are doing when you are using a veloscope, so you have to keep two, three things in mind. First, you need to place yourself a pair of goggles, and a place of goggle on the page on the face of your patient so that the light emitted is not entered into the eyes, because it will cause problems. Okay, so when you are like starting the light, uh, you need to have a good detection and keep it in 30 to 40 seconds, because 30 to 40 seconds will take time period to activate the cells. Okay, and when the cells are activated, you will see the signs of activation, and the light color will be a little bit changed, because if it is emitting blue light, then it will be changed into green light, light green color. Light green color will appear around after 40 to 45 seconds. Okay, and if it is a malignant lesion, then the darker green color will appear, and it will be shown around 1 minute, around 1 minute, 55 to 55 minutes. Okay, so this is a thing. So there is a little bit variability to in
All right,
patient
sir.
to
Thank you
patient as
very
well.
much.
Yes. Any other
Sir,
question?
we have another question
Yes.
from Shehzadi Mehak. She is asking, what emerging diagnostic tools or techniques show the most promise for early detection of oral cancers in resource-limited settings? And my question is that how cost-effective are they?
Okay, both are the good question basically. So the I would go with the liquid biopsy or salivary diagnostic. The reason I told you, the salivary diagnostic will be the cost effective if you ask me, because it doesn't require a lot of your payment. Okay, but on liquid biopsy has the more promising result, if you ask me, the what literature says. Okay, so liquid biopsy has more potential of giving the more accurate detection than the salivary diagnostics, salivary biomarkers. Okay, so liquid biopsy will be on the first level, and second will be salivary diagnostic. And I would, for the diagnosing and for just initial assessment, I would highly suggest to go with the fluorescent, autofluorescent technique, which is basically a veloscope if you are using veloscope. Okay.
All right, sir. Thank you very much. We have another question from Dr. Bisma Jamil. She's asking, what preparation of oral cavity is required for veloscopic accuracy? Like such as patients are supposed to clean their mouth with some antimicrobial mouthwash or to eliminate confounding from fluorescent microbes, microorganisms.
Yes, basically uh, as I told you that you need to prepare the patient basically before it. You need to clear all the factors that are present in the mouth. But in some clients, you just need to just have their mouth washed. It could be with the mouthwash, or it could be with just water as well. Just the mouth need to be clean, and there should not be any foreign particle. Okay.
All right, sir. We have another question. What is the cost of liquid biopsy and salivary analysis in Pakistan?
Uh, I haven't checked it, to be honest, but it is expensive. Liquid biopsy is expensive, and salivary diagnostic it is not much expensive, but both are in, I guess, above 5 to 6,000. Above 5, these are expensive a little bit.
Um, all right, sir. Which of these are available in Pakistan?
Salivary diagnostic is very much available. Basically, salivary diagnostic is the same type of the thing which we were doing in when we were having a COVID, in the era of COVID. We were taking a swab from the saliva. It is just the similar thing.
All right, sir. Thank you very much. We have another question. Will this device, Veloscope, I think, will be able to detect any cancerous growth beneath the basement membrane?
Mm, not very much. It will show just above epithelial. Basically, it just if you see, it can let you know a little bit about grade 1 or a little bit about grade 2. Grade 2 will be a little bit involving a basement membrane, so a little bit you can say, but it will not much show the promising results in the basement membrane. But it will show on the upper level of the epithelial cells, because basically it is emitting the epithelial cells, disrupting the epithelial cells.
All right, sir. Thank you very much. Thank you very much for the question answer session, for the insightful presentation. I think our audience is pretty much satisfied. And I think, sir, and everybody is appreciating the presentation and the way you presented it. Thank you very much, sir, for your time once
That,
again, and thank you, audience, for asking such amazing questions. And now I would like to hand over the mic to Dr. Ghazala, and she'll be continuing further progress of symposium. Thank you, Dr. Farooq, once again. It is mandatory for the audience to kindly fill the feedback form so that they can be presented with the participation certificates. Thank you.
Assalamu alaikum and a very good day, fellow professionals. I'm Dr. Ghazala Naveed, Managing Director at Pride, and it is my distinct pleasure to introduce Dr. Carolina Benitez, a renowned dentist and international speaker from Uruguay, South America. With a strong academic foundation, Dr. Benitez holds a doctorate in dentistry from the University of the Republic of Uruguay and a master's degree in laser dentistry from RWTH, Aachen University, Germany. As an accomplished professional, Dr. Benitez is an active member of several prestigious organizations, including the International Society for Laser Dentistry, ISLD, and the World Dental Federation, FDI. She is also the founder of LDA, the Ibero-American Dental Laser Academy, and is also the member of the Scientific Commission and AAIZ, Ocean Dental Laser Center, Germany. Her expertise spans multiple areas of dentistry, including laser dentistry, endodontics, and implantology. Dr. Benitez is a sought-after speaker, having presented at numerous international conferences and events. We are honored to have her share her insights and expertise with us today. Please join me in welcoming her to our symposium. Good morning, Dr. Benitez. I reckon it's morning over there, right? Can you hear me, Dr. Benitez?
Good morning here. I need to share the screen.
Yes. Do you want to share the
Or
screen?
not? Yes. Wait,
If
please.
you want to share the screen, yes. Okay.
No, stay one. Good morning for everyone here in South America, in my country. So stay in Uruguay, near the Argentine, and my borders with Brazil. And it's a pleasure for me stay here and there in this meeting because it's a very interesting meeting, I think. And hi, Dr. Gastola. Thank you very much, Dr. Farooq Muhammad, and all colleagues. I listened the other lecture. It's very nice, very beautiful, and I think Pakistan is a beautiful country. Yes, have the rich, have the advance. It's a big country, similar to Brazil. And for me, Pakistan is I like a lot the example Kashmir in Spanish, but
Thank you for your kind words. Yeah.
sorry, my first language is Spanish, and but Kashmir is very rich. I like a lot this part, I think, and Kegra, the Salt Rose too. Okay. My topic is I try to information the technology for the cancer, yes, and my topic is laser. The laser name mean light amplification, but simulated but emission for radiation. Yes, today we can improve the patient the quality of life. Yes, now and today and think the science, the 8, 9 years old, my main and my work in the clinic is in laser mode because this technology help a lot and have the treatment more advanced and more comfortable for the patient. Yes. The laser is light. Yes, it's light, not common light. Have one here, no sé, I try to see the doctors. The laser is light, but no is common, no is common light. It's monochromatic. Yes, different, have the different tips. It's monochromatic, directional, coherent, and selective. It's very selective for the tissues. Yes, the laser need the machine have the different laser, different type of laser, and laser have the power. This is important. Our team in Germany, our mentor is in Germany, in the Aachen Dental Laser Center, and my university is Aachen University, Germany, and always say need the control, the important in laser, need the control the parameters, not only come the parameters and the protocol, the company, the different company, the laser, need to control these parameters. Yes, and depend the treatment. Yes, in this case, in cancer, today the laser is very advanced and help and have the treatment for this disease in the world, not only here in the world, but need to understand this technology. The light is monochromatic, directional, coherent, and selective. Yes, and need have the power. What is the difference? Example, the power come out on the light and come the power. When the power touch the tissues, soft tissues or hard tissues, the tissues change, depend the tissues, change the power and the thermal energy. This is the difference. And depend, have the different treatment in laser, endodontic in disinfections, and surgery is very important in surgery in biomodulation, and cancer, and oral mucositis and dry mouth prevent. This is the topic today. I try to information this part, what is important, because what high the quality life the patient in the clinic, on the hospital, and need to know what is the tip, the different laser. Yes, have the diode laser, have the different wavelength 910 nanometer, 940 nanometer, and this is the diode laser for only soft tissues. Have other laser for hard and for soft, the erbium chrome 2007 90 nanometer. Erbium Jag is a good to no, I say nothing the company, because have a lot of company in the different country. You know, it's this nothing for the company. And in 2940 nanometers, the erbium Jag. And it's important for the cancer, because I repeat, today our area change in the world. Yes, not only here, because all the time they stay in the congress, in the course, in the conference, in different place. I try to learn all time, or the cure is all time in this part learn. Yes, this is my mentor, Professor Dr. Norbert Gutner, say the laser noise only you touch here the screen and put the power is 3 watt or 3 watt, put the hertz, how many seconds. No, need to understand, you need to change the screen, need to change because depend the patient is the child or is the older example, the tissues is different. Yes. Hi, Dr. Gasala. It's okay?
Yes, yes. So, according to
Yes.
what you've told me, the lasers used in dentistry are different from those used in oral head and neck cancer.
In
Are they two
cancer?
different kinds of?
The cancer?
Yes.
Yes, in cancer, in cancer, the more complication in the different patients. Yes, because here have the incidence is very high, the different cancer. The more complication is the oral mucositis and serostomy. Okay, this is dry mouth have the problem the patient for eating for your qualities life common because change and need to change sometime the diet and have the problem in the mouth and try to first prevent with the different session the laser with laser I use in this part the laser no high laser the different low laser or less pardon sorry and try to prevent the oral mucositis or dry mouth. Yes, have the different protocol and parameters according Aachen Dental Laser Center and according the patient having my clinic or and work with the team try to work with the team the doctor in medicine but now the doctor in medicine try to understand this part que need need
So
the
you work with
expert in
oncologists,
laser.
right? Okay.
Yes,
So
yes,
you work
this
with
is
oncologists. Okay.
good. It's good for profession because sometimes here
Hmm.
in this continent, in America, North America or South America, more here in South America, the doctor in medicine, oncologist, radiologic, all the medicine, this team for the cancer, no understand it. They understand the dentist. Yes, and now yes, have a lot of patients for this part more than oral mucositis or dry mouth because is have a lot of treatment for cancer the patient and in cancer the back and the neck pardon sorry the neck and the hair and the mouth the treatment is sometimes radiotherapy, immunotherapy, chemotherapy, and biology treatment. And have depend the treatment if the damage the tissues, the our area. Yes, have a lot of problem. The inflammation. This is the inflammation. Not have the have the come the source and the difficult for eating. And por ejemplo the source mouth and in the gum open and come the blood and have the infection. The laser is very nice because all is benefit. Yes, not have nothing nothing dangerous because it's only protect need the glasses for these glasses example this according the laser use have the number here. This is for diode laser, erbium laser, this other. Yes, the glasses is important for the glass is important to protect the assistant all in the clinic for the patient. Only the glasses, because the light noise dangerous. Need to ignore the parameters are control and ignore is benefit for the patient, no? Por example, in patient the cancer, no, the prevent the oral mucosity. Need to the laser come with the power, example 1 power or 0.5 power, and go to the different tissues, the tongue, in the gums, yes, and try to prevent the oral mucositis. Pero need the diode laser, need the chromophorus, melanin and hemoglobin. In this manner, enter the energy in the tissues and uh, uh, produce the more irrigation in the tissues, prevent inflammation, is analgesic. This is one prevent, yes. And then the treatment, the cancer, depend what is the protocol and parameter used in the patient.
Okay, so I have a few questions for you in the chat. So, Dr. Harim Fatma, she is asking, can laser be used to treat salivary gland diseases as well? Like you said, mucositis, etc. So, can laser be used to treat salivary gland diseases?
What is the relevant frequently? This is the question?
Yes. What is? No, it's the first two questions before, like from this one.
Stay in the chat.
Yes. Can laser be used to treat salivary gland diseases?
Can laser be used to treat salivary gland disease as well? Yes, of course. Yes, of course. Because sure, because when I have the patient when come sometimes not have your mouth stay dry because the gland salivary gland stay damaged, stay inflammation. Remember, please, the different treatment in cancer not only go to the cells, the cancer cells, go to the healthy cells. Entonces, all is the complication is the problem. Y sometimes when I stay with the different protocol and session, the laser in my clinic or in the hospital, the patient say, I feel calm the water in my mouth, because it's the one more complication, not only here, all over the world. This complication, the glands salivary is sometimes is very damaged. Yes.
Okay. Then moving on to the next question. My question,
Yes.
Dr. Bisma Jamil, she's asking, my question is about which patients the laser usage is contraindicated, if there are such. Like in which patients you cannot use laser?
I think depend the clinical history. Yes.
Okay.
The clinical history, always need to perfect clinical history. You have the always need to question the doctor in the hospital. For your doctor, go and say, example, the patient will have the problem in your heart. marcapasos, the chip have in your heart. This is only, I think, the problem in the laser. Yes, when have the disease in your heart. But noise or noise not have the contraindication, the laser a lot, no. The laser is analgesic, is good for cicatrization, reparation the tissues, because reparation the cells, and the bacteriostatic, and for inflammation and infection too. And
Okay, so it's
reparation
comparatively safer.
the tissues is more quickly, because in surgery is very common here, use the laser, for example, biomodulation. On the reparation, the tissues is more quickly and sure. The laser is sure.
Okay, so moving on to the next question. What is the wavelength and frequency of laser used? And what is the safe window? And how does it vary with different diseases? Like, do you use different wavelengths of laser for different diseases?
Yes, sometimes say in the Congress or the different conference, say, what is the best laser? I have a lot of laser now in the world, and in the dentist stay in this part, in this area. What is the best? I say is the question in Germany or in here too. No have the best. It's the why you feel well, and I think the combination, the wavelength, is important for the result, the different treatment with laser. Yes, this combination, the 660 nanometers, for example, biomodulation, or the other combination, 940 nanometer, the wavelength, because important is the wavelength in the treatment, or to change other laser, the erbium, because what happened, the erbium is very expensive, the cost is expensive, and this is change the wavelength, but not have the one only, it's the combination, because I try to example in cancer use the different, not only one.
Okay, so the
Because
next question.
it's safe it's safe because the laser is safe. Today is safe. The laser noise is new in our profession. The first laser is the ruby. Come in the have is other problem. The other problem is the screen. Now the company all time come with different laser, more well is safety. Need to in Germany all the topic, the safety, and the safety in my clinic, in the patient, the safety is with the glasses, but the laser no is dangerous.
Okay, so there's another question from Fatima Ozoma. Is there any particular stage of cancer where the laser should not be used, or is it like as safe as you say it? Is there any stage of cancer that we should not use the laser? At any stage of cancer, or can we use it? Is
No,
it safe?
use in all. No, use in all cancer. No
Okay.
problem. No
Can we
problem.
use it in
Need
implant
to
patients?
know what is the step use the cancer. For example, have the patient stay in your home because not feel well in with the chemotherapy. not feel well and need to stay in your home, have this cure when the patient not feel well for the treatment because it's very invasive, the treatment, the cancer, the mouth on the neck and the hair is very invasive, the treatment, the doctor in medicine, the oncologist, and sometimes the patient, I think 15 days and stop, and then again the chemotherapy. Stop and again. This is the accumulation,
Regular
the radiation is accumulation, and sometimes the patient not feel well. But this is I try to coordination with the doctors in the hospital when come with the in my clinic the or go to the hospital when come in my clinic the patient and what is the session because the section the step depend the my protocols and parameters.
Okay, so the audience and the participants, they're loving your energy. I've got really good messages for you. So Dr. Bisma Jamil,
What?
she's
What?
saying, gracias por
Don't
la
understand.
respuesta, Dr. Benitez. Okay. And then there is Dr. Saman. She's saying, thank you so much, ma'am, for such insightful sessions. And Dr. Shehzadi Meg, she's saying, love your energy, ma'am. Thank you so much for joining us today. High appreciation
Thank
for
you
your
very much.
efforts.
Thank you very much.
Yes.
Here I have the question because I see the chat. Is an implant patient would use it?
Yes.
Yes, of course, using implant today for
There's also a question by
biomodulation, for the cut, for not cut similar a bisturi, cut in the evaporation, different. Yes, depend what is the 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 the, the laser use, the diolaser or the erbium. Today, today have the my parent in laser put the implant with laser.
Oh,
Because
that's great.
yes, put implant with laser and it's very nice the result because disinfection sometimes
Okay.
the laser disinfection and in the and put the laser very and not need the suture sometimes too because the cut is very knitted.
Okay. Okay. So it's a precision cut with laser. So the people are actually loving your jhumkis. That's an
What you
off-topic
say?
thing, but they're loving your earrings. They're called jhumkis in Pakistan. So they're loving your earrings, what you're wearing in your ear, and they're
Yes,
showering love on you.
yes. What is
So,
more question, please? Or need to
do you have any
explain
more
more?
questions, guys?
Because the here the meat is the cancer and need to see understand more, explain more. Not have the
Okay, so
problem.
there is a question from Dr. Shanze. She's asking, is there an exclusion criteria for these lasers?
What is the question? Wait. Stay in the chat.
Yes, it's in the chat.
The bacteria. What do you say? The bacteria.
Exclusion criteria. Criteria. Let me write it again.
Mm-hmm. Cried. Sorry, no understand the question. Wait. Amazon. Exclusion criteria. Wow. What is criteria? What is mean criteria? Explain me more. Hi.
Exclusion criteria, I think she wants to know if there is a way, like, in different patients. Like sometimes it's the skin color that we cannot use lasers. I think she's comparing those lasers with the other lasers that we use on skin, not for the surgeries.
Is criteria, any criteria in other similar, please? No understand.
No, I think let's move on to the next question. There is, how does laser excision impact long-term prognosis and recurrence rate in oral cancer compared to conventional surgery? Like Dr. Hajra, she's asking, okay, is the, like you said, the laser is very precision. Yeah, it's, we get very precision cuts from it. So is there a way that disease can reoccur after it's been excised with the laser? Is there a chance for reoccurrence?
Exclusion the technique, the older technique. This I say. Hi.
No, let me just send you this question again. How does
Have the
laser
different the conventional surgery and the surgery with the laser. This is have the difference. Yes.
Okay, okay,
Because
yes.
the laser is very selective. Go to this part. The incision is perfect. It's in seconds. Is no need the suture. Sometimes no need analgesic, antibiotic. Sometimes depend, and the prognostic and the result the patient is different. Is nice in the time in macroscopic and microscopic is different too when use the laser, the surgery with the laser, and surgery with bisturi, the conventional.
Okay, so someone has.
This is it have the difference different because the tissues respond the different manners. Yes.
Okay.
And the laser today cut the bone.
Oh, like it's that.
Not only so the bone.
Okay, okay. So basically, it has that.
Pero it's the erbium. This is the other laser. The erbium can need the water to work. Here, the diode laser only is for soft. It needs the melanin, the chrome of melanin,
Okay.
and hemoglobin for need to the energy enter in the tissues. And in all the our mouse have the melanin, the bacteria have the melanin too,
Yes.
and the hemoglobin. The bacteria for this infection is is very amazing because the melanin have the bacteria have the stay inside the bacteria and is explosion the bacteria and kill the laser.
Oh, so this is like, I understand what you're trying to say. Dr. Haja, did you get your answer?
Yes.
Okay, so we're going to move to the next question. How are the oral cancer rates and patient attitudes in your home country versus in Germany? Yes, Dr. Bisma is actually asking you to compare the oral cancer patient occurrence that you have in your home country, that is Uruguay, and compare that with Germany. Like you have experience of both countries, so she wants to know what is like the comparison of oral cancer.
Yes, I understand.
Mm-hmm.
No have the different attitude. The patient like it. No matter stay in Germany and Pakistan or and here in South America and Uruguay or in Argentina, the patient like a lot they use the laser because need to know what is the technology and involucration with the technology because need to education. I need to the education the patient and say explain. I like a lot explain first for understand and and stay with me with the treatment. Yeah, this is important because the patient see I see touch pass the light. No, no is pass the light. No is this manner. Need to know the parameters and the protocols and study for understand more. Yes, need to know what is the laser inside the machine. Why? All is why. Entonces, need to explain. I think change the work, your common work, yes, change.
Okay. So,
Yes.
I have one last question that how does laser therapy improve the quality of life of cancer patients? Like, how can it improve the quality of life? They're actually getting like different therapies, radiation, chemo. Does laser have an edge to these therapies? Like, is it better than those therapies? Can we see it as a replacement of these therapies in future?
Reply, please, because I try to understand you. Yes.
My question is, how does laser therapy improve the quality of life for cancer patients? Like we have different therapies for cancer patients, radiotherapy, chemotherapy, right? So, is laser
Yes.
better than those therapies?
No, no,
And can
no,
laser?
no, no. No, here they only talk about the laser in uh, no the I think radiotherapy, chemotherapy, all biological treatment, immunotherapy
Okay,
is different. No, no, nothing similar to laser. No, I think stay in this moment in different paper study about the the laser is good for the treatment the cancer, but no, this is other
surgical
topic.
part of the treatment,
This
right?
is other topic. This is other topic because stay in a study with the benefit the laser is good for the cancer, but this is other topic. No, is for
Okay, okay.
for yes, stay in advance. Is the technology, know this technology is used for the, yes, surgery, I think the carcinoma, need to know, talk about the carcinoma, the other colleagues need to know what is the CS a little is older, need to know the tissues and the laser no problem to cut for evaporation the carcinoma. Is the result I think is more well.
Okay, okay. So I
Is
think we're
more
done with the question.
is the reparation the tissues is in seconds and have the different imaging for the macroscopic and microscopic, yes, in the lesion.
Okay, so I think that was our last question. Thank you, Dr. Benitez, for a very insightful session and for sharing your knowledge. We are honored to have you with us. I hope that we have more sessions with you in future. And thank you for imparting your knowledge.
Thank you very much for all. And I try to visit Pakistan. I need to know the university I like. I try to not say what is university, the dentistry in Pakistan. I think I have a lot and try to know the group. Yes, of course, why not? And I don't know, in the end years, go to the Emirates and Dubai or Abu Dhabi and go to Pakistan too. Pakistan is my two or second home because Alhamdulillah is a beautiful country. Pakistan Zindabad.
You are beautiful as well. You're a beautiful soul. That's why you
Thank
see
you
And
the
so much,
beauty in
ma'am.
Shukriya,
others.
and yes, and shukriya and alafis.
Okay, Allah Hafiz.
Thank you very much.
So, with that, we conclude our session. I would like to invite Dr. Saman and Dr. Tuba for the ending keynotes.
Thank you, Dr. Ghazala. Amazing session. And I can see the participants engaging in Spanish. Wow, wow, zabardast.
Thank you, our audience, for being here and asking so much insightful and informative questions. Thank you, esteemed speakers and guests, for giving us your time and telling us much more about oral head and neck cancer and actually making this month awareness month for all of us. Special thank you to Dr. Carolina Benitez for taking out your time and sharing such insightful information with all of us. We are truly honored to have you and looking forward to much more sessions with you. Thank you. I would request the audience to kindly fill the feedback form provided in the chat box regarding today's symposium. As we draw this insightful symposium to a close, I would like to take a moment to reflect on the meaningful discussions, exchange of knowledge, and shared enthusiasm that mark today's event. We have had the privilege of hearing from distinguished speakers, engaging in thought-provoking sessions, and exploring new perspectives that will undoubtedly contribute to the advancement of our field. Your active participation and presence made this symposium not just successful, but truly inspiring. On behalf of the entire team, I extend our deepest gratitude to our honorable speakers, our guests, and every individual who contributed to making this event a memorable one. Thank you once again.
As we wrap up the sessions for today, I would want to sincerely thank each of you for being part of this enriching and inspiring day. The energy, engagement, and insightful conversations we have had witness to reflect the true spirit of the collaboration and the shared commitment to advancing our field. Today's session has set the tone for what promises to be an equally stimulating day tomorrow. We are excited to continue the journey with you, exploring new ideas, learning from esteemed experts, and building valuable connections. We look forward to welcoming all of you again tomorrow. Tomorrow is day 2 symposium, right? Don't forget to attend that as well. Well rested and ready for another impactful day. Until then, thank you. Take care. See you. Allah Hafiz. Thank you so much for attending.